Yeah, I will move on to the next topic, Colles fracture. Okay, there is no question paper without Colles fracture. As I said, no, it's a distal radial fracture which is extra-articular. That's called a Colles fracture. The definition goes like this. This named after the great Sir Abraham Colles. This is otherwise the original name of its Potow's fracture. Sir Abraham Colles. You won't believe, guys, this is 2023. In 2009 or 2010, the question asked was, who coined the term? Colles fracture was demonstrated by Abraham Colles, Ingraham Colles, Graham Colles, and the fourth choice I had forgotten. Okay, this was a question and this was asked in Ames. To this extent they are asking, that's why always I am typing the full name. I don't know what question they will ask. Abraham Colles. Okay, so Abraham Colles, it's called Colles fracture. It is not just fracture lower end of the radius, but fracture dislocation of the distal radial nerve joint. The fractures occurs 2.5 centimeter above the carpal extremity. So it is extra-articular. It is extra-articular. When it is intra-articular, that's called Barton. Okay, yes. Fracture at corticocancellous junction. It is the most common of all fractures in the elderly. This already I told you. Most common fracture of newborn clavicle, most common fracture of childhood supracondylar, most common fracture of young adult scaphoid, most common fracture of elderly Colles. Most common mechanism is fall on outstretched hand. Fall on outstretched hand in extension. Fall on outstretched hand in extension. This is the mechanism. Look at here. So fall on outstretched hand in extension. That is the mechanism. Okay, of Colles fracture. Then, what are the 6 components of Colles? Gold standard question. And I had given you a mnemonic DILS. Just remember like this. Okay, so dorsal tilt, dorsal displacement. Okay, this stands for D. Then comes impaction. This stands for I. Then comes lateral tilt, lateral displacement. Okay, this comes L. Then supination. This stands for S. DILS. It's very simple. Dorsal tilt, dorsal displacement, impaction, lateral tilt, lateral displacement, supination. Why these 6 components are very important? Only when you understand these 6 components, you can correct Colles fracture. Because you know pretty well, treatment of choice of Colles fracture is essentially conservative, no surgery. It's like clavicle, conservative. How to reduce Colles fracture and keep it in a Colles cast? You should know this. You should give forces just opposite to this displacement so that it will get neutralized. You will get good anatomical reduction. Okay, so these 6 components are so important. Clinically, the test is called styloid process test. Clinically, the test is called styloid process test to diagnose a Colles fracture. Suppose X-ray, obviously, easily you can diagnose. Suppose you are working in a center where X-ray machine is not available. Clinically, you can diagnose Colles fracture. What is the styloid process test? Classical clinical finding. Normally, when you palpate the radial styloid and ulnar styloid, radial styloid is 1.3 centimeter distal to ulnar styloid. This is normal. If Colles fracture happens, radial styloid and ulnar styloid will lie in the same line. This is called styloid process test. And the classical deformity of Colles fracture is called dinner fork deformity. Why the dinner fork deformity? This is because of the dorsal tilt and dorsal displacement of the distal fragment. Exactly like a dinner fork it will go. So called a dinner fork deformity. Treatment of choice is close reduction, below elbow POP cast in. Look at the diagram. Palmar flexion, ulnar deviation. Okay, this is the important thing. First you are giving traction, make it in full palmar flexion, make it in full ulnar deviation. This is called Colles cast. This is called Colles cast. This is called Colles cast. How when you do like this, how that displacements are corrected. When you give traction, impaction is neutralized. Impaction is neutralized. Impaction, traction. When you do dorsal palmar flexion, when you do this palmar flexion, dorsal tilt, dorsal displacement are neutralized. Dorsal tilt, dorsal displacements are neutralized. You do ulnar deviation, lateral tilt, lateral displacements are neutralized. Okay. And you are putting in full pronation. You are keeping in full pronation. So, supination is neutralized. So, what are the 6 components of Colles? DILS. Dorsal tilt, dorsal displacement, impaction, lateral tilt, lateral displacement, supination. All these things are countered or neutralized by traction, putting in full palmar flexion, ulnar deviation in full pronation. This is called Colles cast. All the displacements are neutralized. So, it will heal in a good anatomical reduction. So, this is called Colles cast. Very, very important. Practically, as an orthopedician, daily we are seeing cases. How many thousands of cases I would have reduced and done in these 20 years of experience. And you immobilize this for 6 weeks. Excellent prognosis. Okay. Excellent prognosis. Then, what are the complications of Colles fracture? Most common complication is stiffness of finger. Most common complication, stiffness of finger. Second common complication, malunion, and that is called dinner fork deformity. That is called malunion. That's called dinner fork deformity. Okay, malunion, maluniated Colles. Most common nerve that is injured in Colles fracture is median nerve. Median nerve, most common. And most common tendon, it is extensor pollicis longus. So, okay, most common complication is stiffness of finger. The second common complication is malunion. It causes dinner fork deformity. Most common nerve that is damaged is median nerve, and most common tendon that is damaged is extensor pollicis longus tendon. Okay. So, just the point I want to stress is, when the patient falls on outstretched hand in extension, there is dorsal displacement of this distal fragment. This is called Colles. When he falls in flexion like this, the distal fragment is displaced ventrally, and this is called Smith fracture. This is called Smith fracture. Reverse Colles is called Smith. When I fall on outstretched hand in extension, Colles will happen. When I fall on with my hand in flexion, that will cause reverse Colles, that otherwise called Smith fracture. The classical deformity of Colles is called dinner fork deformity. Classical deformity of Smith fracture is called Gordon-Spade deformity. Gordon-Spade deformity. Okay, Gordon-Spade deformity. Treatment of choice of Colles fracture is conservative. Treatment of choice of Smith fracture is surgery. Okay, you have to fix it with what is called the Ellis plate. It's called Ellis plate. Coming to the next important chapter, scaphoid fracture. Okay, I told you most common fracture of young adults. Most common fracture of young adults. And all this anatomy, everything you know. Most common carpal bone to be fractured is scaphoid. There are 8 carpal bones. Most common carpal bone to get fracture is scaphoid. Okay. Most common site of scaphoid fracture. You know, scaphoid has proximal pole, waist, distal pole. The most common site of scaphoid fracture is waist. Waist of scaphoid. Okay. Fall on outstretched hand is the mechanism. And look at here. This is scaphoid is gone. Waist of scaphoid. This is the waist of scaphoid. This is the most common type. This is proximal pole fracture is the second common type. This distal pole, this is the rarest type. Okay. So, if they won't ask these other 2 types, most common site of scaphoid fracture is waist. Most common mode of injury results fall on outstretched hand. Most important clinical sign is, everyone knows this is anatomical snuff box. So, it is fullness and tenderness in the anatomical snuff box is a very, very important classical clinical sign. And whenever the waist of scaphoid is gone, totally it is displaced. The classical deformity of scaphoid fracture is called, okay, so I said the classical deformity of Colles fracture is called Dinner-Folk deformity. Classical deformity of Smith fracture is called Gordon-Spade deformity. The classical deformity of a displaced scaphoid fracture is called, okay, is called humpback deformity. Humpback deformity. It's called humpback deformity. And there are two important clinical signs to demonstrate scaphoid fracture. One is called scaphoid lift test. Pain with the dorsal and volar shifting of the scaphoid. You catch hold of here, do like this, dorsal volar shift. Severe pain is experienced in the scaphoid. That's called scaphoid lift test. The test which commonly I do and most of the orthopedicians do, it's called Watson's test. Watson's test. Pain, see, make the patient put his hand over a table like this. Pain is produced when the wrist is moved from ulnar to radial deviation. When you do like this, if there is scaphoid fracture, patient can't bear the pain. This is called Watson's test. Scaphoid lift test you are doing in this position, in this axis, okay, from anteroposterior axis, here sideways. Watson test is done sideways. Make the patient to keep the hand on the table, in the ulnar side, ulnarly deviated hand. Ask him from ulnar deviation, ask him to move towards radial deviation. Severe pain is experienced along the scaphoid, and that's called Watson's test. That's called Watson's test. X-ray view of choice for scaphoid is called scaphoid view, which is nothing but an oblique view of the wrist. It's oblique view of the wrist. That's called scaphoid view. The fracture line, normally you are suspecting clinically a case of scaphoid fracture. Normally you should see in a very good digital X-ray, you should be able to see at least a hairline fracture. The question they are asking in INISET, AIMS guys, specifically AIMS exam, what they are asking, clinically you are suspecting, please focus your attention on me, don't see the board, look at me. See, you are clinically suspecting a case of scaphoid fracture. You took a good X-ray. X-ray is not showing you scaphoid fracture. What will you do next? This is the question. Okay. You are clinically suspecting, that is, pain and tenderness and fullness along the anatomical snuff box is there. Watson's test positive, scaphoid lift test positive. Clinically, you are strongly suspecting scaphoid. Young adult, fallen outstretched hand, everything is there. Clinically, strongly you are suspecting scaphoid fracture. X-ray is not conclusive. X-ray is not convincing. What will you do next? This is the question. 3 times repeat in a set. Scaphoid fracture. What will you do next? Treat it like a scaphoid fracture. Give him a scaphoid cast. Give him a scaphoid cast. I will tell you the reason why. Give him a scaphoid cast. Repeat the X-ray after 3 weeks. Repeat the X-ray after 21 days, 3 weeks. Same oblique view with the cast. Okay. Check for any healing fracture line. Suppose a thin hairline is there, which was not there. Clinically, you are suspecting scaphoid. X-ray is not showing. Just give him treat it like a scaphoid fracture. Repeat the X-ray after 3 weeks. Look for any healing fracture line. If there is healing fracture line, leave the cast for 10 weeks. So 3 weeks later you are repeat. So leave for another 7 weeks. Leave it. Okay. Then remove the cast. Everything will be all right. Even after 3 weeks, you are not seeing any healing fracture line, no signs of fracture in the X-ray. Leave the cast and leave the patient free. This is what we should do. This is what practically done. Why? Dear friends, scaphoid is a very small bone but a notorious bone, I am telling you. When you miss a scaphoid fracture, 40% of the cases, because you know the anatomy, the blood supply of scaphoid. So, for example, just you remember, just imagine this as a scaphoid. Okay, waist of scaphoid fracture has happened. Normally, blood supply, this is the distal pole, this is the proximal pole. Blood supply comes from the distal pole. When waist of scaphoid is gone, no, this proximal portion will go for avascular necrosis. Avascular necrosis. What is the chance? 40%. However well you treat, no, 40% cases are going for avascular necrosis of scaphoid. This is the problem. This is a small bone but a notorious bone. And where it is happening? Young adults. Once the patient had developed avascular necrosis of proximal pole of scaphoid, he will have lifelong wrist pain. He will have lifelong wrist pain. Then he will never leave you. That's why over treatment is justified in scaphoid fracture than under treatment. When you clinically suspect scaphoid, treat it like a scaphoid fracture. Okay, right? I think by this time you would have understood the significance why I am telling this point. MRI detects scaphoid fracture much earlier than X-ray. So if they ask the investigation of choice, MRI is there, vote for MRI. MRI is the better investigation than X-ray. So coming to treatment in undisplaced fracture scaphoid, most of the scaphoid unites by scaphoid cast for 10 weeks. See, to my knowledge, dear friends, even very long bone like tibia or humerus or radius and ulna, we are immobilizing only for 6 weeks. Such a small bone, we are immobilizing for 10 weeks. You see, you take the textbook and refer. Okay, because of the fear of avascular necrosis. Okay, so undisplaced scaphoid fracture is mostly it's treated with 6 to 10 weeks of scaphoid cast. Scaphoid cast is a below elbow POP cast in, this is called, okay, the scaphoid cast, below elbow POP cast in tumbler holding position. This is called glass holding position or tumbler holding position. Okay, for 10 weeks, that will solve the problem. If it's a displaced fracture, you should do open reduction internal fixation with what is called a Herbert screw. The peculiarity of Herbert screw, already I told in the main class, I had explained it very in a detailed fashion. Herbert screw, when you see, screw, one part is missing. You are not seeing the head. So Herbert screw is a headless screw. Herbert screw is a headless screw. Okay, that means the screw gets buried inside the bone. That's the treatment of choice. So undisplaced scaphoid fracture treatment conservative. That's called a scaphoid cast. Other is called Bowler gauntlet cast. It's called a Bowler gauntlet cast, conservative. If it's a displaced scaphoid fracture, treatment of choice is surgical and that's by Herbert screw. Coming to the next important fracture, Bennett fracture. Two fractures you should know, Bennett and Rolando. Bennett fracture and Rolando. Both fractures are intra-articular. Intra-articular fracture happening in the base of the first metacarpal. Bennett and Rolando are intra-articular fractures that is happening at the base of the first metacarpal. If it is oblique, only one plain oblique fracture line is there. You see here, that's called Bennett. When it is comminuted into thrown small many pieces in the base, okay, like this, comminuted more than one fragment, that's called Rolando. That's the difference. What is the main difference between Rolando and Bennett? Both are intra-articular fractures that are happening in base of the first metacarpal. If it is a plain oblique fracture, that's called Bennett. When it is comminuted fracture of the base of the first metacarpal and intra-articular, that's called Rolando. Okay, this looks very simple, no? So this is the proximal, the small chip is the proximal fragment. This big chunk, this metacarpal is the distal fragment. When you see, the distal fragment is attached to an important tendon called abductor pollicis longus tendon. So this is a intra-articular fracture and one end this is attached to abductor pollicis longus tendon. So it is pulled by a tendon like an avulsion fracture. So it needs fixation. Otherwise this will go for non-union. Again the same thing, it is into multiple fragments intra-articular, so it is fixed with mini screw. Okay, treatment of choice for Rolando is mini screw. Treatment of choice, Bennett of Bennett fracture is open reduction internal fixation with KYS. With KYS. Okay, so this is about Bennett and Rolando. Several times repeat question in Bennett is, what is the hindrance? What is the main problem of Bennett? Because one fragment is constantly pulled by abductor pollicis longus tendon. Okay, yes. Then coming to mallet finger. Mallet finger is otherwise called baseball finger or drop finger. This is result from the injury to extensor tendon of the terminal phalanx. Mechanism is forced flexion of the distal phalanx while the extensors are actually trying to extend. The good example, no, just you are hyperextending, you are tucking a blanket underneath the mattress, some screw or some obstacle is there, forceful sudden flexion of the distal phalanx, what happens, the extensor tendon gets ruptured, that is called, and will go for a shape like this, that is called a mallet finger, like a mallet. Okay, mallet. And acute mallet finger, the treatment should be splinted with what is called a mallet finger splint. This is the only treatment. Okay, surgery is not advisable even if there is fracture dislocation. Okay, so this is mallet. The old treatment before invention of this mallet is a small POP in this position that is called Smiley's cast. This is of historical importance, not now. Okay. Yes. Now let us revise. Very important thing. Most common vessels injured in specific fractures. Fracture clavicle. Most common vessel injured is subclavian. Proximal humerus. Most common vessel that is damaged is axillary. Shaft of humerus. Most common vessel. We are talking about only blood vessel, man, not nerve. Most common blood vessel that is involved in shaft of humerus is brachial. Most common vessel that is damaged in supracondylar fracture, brachial. Most common vessel that is damaged in posterior dislocation elbow, brachial. Fracture both bone, most common vessel that is damaged is anterior interosseous. Anterior interosseous vessel. Interosseous. Okay. So these are the most common vessel damages in upper limb trauma. And coming to nerve, most common nerve that is damaged in fracture clavicle, most of the books are giving medial cord of brachial plexus. I told that's not enough. Should be very specific. Ulnar nerve. Most common nerve. Most common nerve that is damaged in proximal humerus is axillary nerve. Most common nerve that is involved in shaft of humerus is radial nerve. Most common nerve that is involved in supracondylar fracture humerus is anterior interosseous nerve, which is a branch of median nerve. Most common nerve that is involved in posterior dislocation elbow is directly the median nerve. Most common nerve that is damaged in Monteggia fracture is posterior interosseous nerve. Most common nerve that is damaged in hook of hamate is deep branch of ulnar nerve. Most common nerve that is damaged generally in wrist injury is median nerve. Okay, guaranteed one question will come. Okay, so very simple. This, let us revise. Just I am not going to write. I am going to tell. Please focus your attention on me. All these things already I had explained. What do you mean by Holstein-Lewis fracture? Holstein-Lewis fracture is fracture, oblique fracture, lower third humerus with radial nerve damage. Holstein-Lewis. Monteggia's fracture is it is upper third ulna with radial head subluxation. Galeazzi fracture is lower third radius with distal radial nerve joint subluxation. Piedmont fracture is otherwise called Galeazzi fracture. Treacherous fracture is otherwise called Monteggia's fracture. Fracture of necessity is otherwise called Galeazzi fracture. Essex Lopresti fracture is combination of Monteggia and Galeazzi. So concentrate. Essex Lopresti. What is that? Comminuted fracture radial head with distal radial nerve joint subluxation. What is Essex Lopresti? Comminuted fracture radial head with distal radial nerve joint subluxation. So what happened? Comminuted radial head fracture has happened here. Distal radial nerve joint is gone here. Okay. So what happens? No. There the patient will present to you with severe wrist pain. Distal radial nerve joint is gone. Right. Like Galeazzi. But here what happens? Galeazzi distal radius with distal radial nerve joint subluxation. Here what happened? Radial head is damaged. Radial head is damaged. Okay. So what happens? Normally if it's a plain comminuted fracture radial head, what I will do? Just simply excising the radial head. That is enough. Radial head excision is the treatment of choice for simple comminuted radial head fracture. What will happen, sir? If I remove the radial head, what will happen? Nothing will happen. Pronation, supination, everything will be normal. No problem. Okay, only when you leave a comminuted fracture, it can cause myositis ossificans. Many complications are there. Right? Okay. But here, additional to comminuted fracture radial head, what you are having is distal radial nerve joint subluxation. Distal radial nerve joint is gone. So when you remove a radial head, what happens to length of the radius? It is shortened. So every time when I flex the elbow and extend the elbow, radius will go up, radius will come down because distal radial joint is not there. Here the length of the radius is decreased. So when I flex and extend, what happens? No, radius will go up, radius will go down, radius will go up. This is called proximal migration of radius. To prevent this complication, the only treatment or the best treatment that's available for SX low opacity fracture is radial head excision with radial head replacement. When you excise the radial head and replace the radial head, length of the radius is maintained, so proximal migration won't happen. Whatever book you refer, only these 2 points will be given in the topic SX low opacity fracture. Dear friends, you should be very careful. SX low opacity classification is entirely different. That comes in calcaneal fracture. SX low opacity classification is for calcaneal fracture. SX low opacity fracture is different. This. Then comes nightstick fracture. Nightstick fracture is isolated fracture ulna. Isolated fracture ulna. That's called nightstick fracture. Pottow's fracture is nothing but Colles fracture. Smith fracture is reverse Colles. Barton's fracture is a distal radial fracture which is intra-articular. Hutchinson's fracture is nothing but radial head fracture. Jupiter fracture is fracture lateral epicondyle in a child. Lateral epicondyle in a child is called Jupiter fracture. Bennett fracture is oblique fracture, intra-articular fracture at the base of the first metacarpal. Rolando is comminuted fracture, in comminuted intra-articular fracture base of the first metacarpal. Boxer's fracture is fracture shaft of fifth metacarpal is called Boxer's fracture. Fracture shaft of fifth metacarpal is called Boxer's fracture. Malgagny fracture is nothing but supracondylar fracture. Babycar fracture is shattered elbow in a child. Shattered elbow in a child. Okay. So, this completes to some extent the named fractures of upper limb. Okay, friends, we'll move on to the next topic, fracture neck of femur. Okay, just I will tell you only the important points. For detailed discussion, kindly refer the main videos. Fracture neck of femur happens in elderly women, postmenopausal women. Okay, most of the time this is a pathological fracture. Fracture neck of femur is a pathological fracture because it happens in a pre-existing osteoporotic bone very commonly. That is why it's most common in postmenopausal women. So the mechanism is due to trivial fall. Patient won't be having a violent injury or something like that. Just they will go slip in the toilet or bathroom, they will develop fracture neck of femur. Okay, right. And coming to the problem of fracture neck of femur, once know when you read the old surgery books, no, old Bailey and Love, I had read it in Bailey and Love. Orthopedics, a chapter is there in Bailey and Love. Fracture, it has been mentioned like this. People come to the world through pelvis and go out through fracture neck of femur because once upon a time it was a nightmare when somebody develops fracture neck of femur. That is the end of the patient. Okay, why? Because it will never heal. Once fracture neck of femur has happened, it will never heal. The problem, why? What is the thing? Because the blood supply to the neck is femoral head. It is very, very peculiar. It receives blood supply mainly through three important arteries. Number one, it is an interosseous cervical vessel. Interosseous cervical vessel means directly that supplies the neck. This is through medial and lateral circumflex femoral artery. Medial circumflex femoral artery, lateral circumflex femoral artery. You know pretty well this medial circumflex and lateral circumflex femoral artery are a branch of deep femoral artery, profunda femoris, deep femoral artery. So this is one main supply. The next supply is through artery of ligamentum teres. Artery of ligamentum teres, no, through acetabulum. You know, in the head there is a part called, this part is called fovea, and the vessel enters through this fovea through an attachment that is called the ligamentum teres. A vessel comes inside the ligamentum teres and that's called artery of ligamentum teres. A very minimal supply. Third thing, retinacular vessels, okay, in the neck. So when fracture neck of femur happens here, two major supply, that is interosseous vessel and retinacular vessels, are gone here when fracture happens at the level. So head is going for avascular necrosis. This is the problem. The problem in fracture neck of femur is avascular necrosis, head of the femur. That's the main problem. 90% of the cases, textbook says 85%. I am telling in practice, I can say 95%, even 100%. When fracture neck of femur happens, it will never heal. So the main complication of fracture neck of femur is non-union and avascular necrosis of head of femur. Avascular necrosis of head of femur has happened when the patient continues to walk. The shape of the head is altered. It goes, rubs against the acetabulum. What it's causing? Secondary osteoarthritis. That is the thing. That's the end result of fracture neck. In many old patients, they are not able to stand. So they are lying for a long time. They will develop bed sores, septicemia, hypostatic pneumonia. death. That is why once upon a time this was a nightmare. Nowadays, with the advent of many techniques in orthopedics, we are fixing it successfully. Okay, so that's the problem, right? Then comes why there is delayed union or non-union in fracture neck of femur, intracapsular, because neck of femur is an intracapsular part. That means neck is inside the joint. When something is inside the joint is surrounded by what? Is filled by what? Synovial fluid. Synovial fluid. Synovial fluid has an enzyme called lysine. Synovial fluid has an enzyme called lysine. The main function of lysine is to lyse the blood clot. It will never allow the blood to form a clot. But for healing, we know what are the stages of bone healing. You know, first stage is called stage of impaction. Both fragments should come in contact. Second stage is called the electric current induction at the raw surface area, induction. Third important stage is called hematoma formation. Blood clots should get formed in the fracture site, hematoma, because hematoma is the foundation for callus. Only hematoma is there, it is a foundation for callus. Hematoma formation, okay, foundation. If there is no hematoma, no chance of callus formation. There is no chance of callus formation. Okay, so here this lysine is not allowing the blood to clot. So no hematoma formation, no callus formation, non-union. That is the main reason. Number two, normally all of us in the neck area has a very deficient in cambium layer of the periosteum. There is a layer called cambium layer in the periosteum. Only that cambium layer is important for bone formation. When a fracture happens, the periosteum and cambium layer is sound, that part can go for union. If cambium layer is stripped, that's why when you strip the periosteum, that fracture can never heal. That's why while doing surgery, we used to advise the junior surgeons, handle the periosteum carefully, handle the periosteum, don't strip too much of periosteum. Even when you fix it to the plate, the bone won't heal. Okay, so for these two strong reasons, okay, and naturally the part neck is less vascular. So for these three reasons, why fracture neck of femur always goes for non-union. Number one, it is less vascular, it is deficient in cambium layer. Number three, the synovial fluid has lysine. Okay. Yes. Then coming to classification systems, just I am not going to highlight everything because everything in detailed fracture neck of femur we have discussed in the main recording. Kindly go through that. Just this is a revision class. Okay. So the classification systems that are very important, one should know is a broad classification. This neck of femur is divided into intracapsular, extracapsular. Number two, anatomical classification. It is divided into which part is damaged. So just behind the neck, it's called subcapital, which has worst prognosis. Subcapital has the worst prognosis. Subcapital has the worst prognosis. Then transcervical, basicervical. According to Powell's classification, I will explain this with a diagram. According to Powell's classification, type 1, type 2, type 3. Powell's, when the angle is less than 30 degree, type 1, 30 to 50 degree is type 2, more than 70 degree is type 3. Okay. So, fourth and important classification system is called Gordon's classification. Gordon's classification, kindly please note these points. Everything has been already, I had detailed, I had discussed. Just this takes into consideration how is the fracture line, whether it is complete, displaced or not. One. Number two, the trabecular pattern. Grade 1 means incomplete fracture line. Normally a line trabecula between the acetabulum, head and neck. There is a trabecular pattern system. The alignment should be normal between three structures, acetabulum, head and neck. So in grade 1, the trabecular distribution is normal and the fracture is incomplete. When the fracture is incomplete, there is no question about displacement. So grade 1 has the best prognosis. This has the best prognosis. Grade 2. Grade 2, the fracture line is complete but undisplaced. Fracture is complete but it is undisplaced. Trabecular alignment maintained in all three structures. Again, this has a good prognosis. When you reduce. Grade 3, the problem starts. Fracture is complete with partial displacement. The trabecular pattern is altered. So you have to fix it correctly. Grade 4, complete fracture, totally displaced, and the distal fragments get externally rotated and head comes in normal position. So trabecular pattern assumes to be in parallel orientation, but that is not right. And book says this has the worst prognosis. Always the type 4 Gordon's. This question they had asked several times. This question they had asked several times in the entrance, no? Which has the best, which has the worst? Gordon's 1 has the best, Gordon's 4 has the worst prognosis. Now, see the diagram. Broad classification. When this is, see, this is the neck. This portion is the neck. This portion is the neck. When it is inside the capsule, this is intracapsular, this area. Trochanter, everything is extracapsular. So this is intracapsular, this is extracapsular. This is a broad classification. Next thing is anatomical classification. This is your head. This is your head. This portion is the head. This portion is the neck. This is greater trochanter. This is lesser trochanter. Okay. So when a fracture happens just below the head, this area fracture is happening. This is called subcapital. This is called subcapital. This has the worst prognosis. Highest chance of avascular necrosis is at subcapital. When it is below subcapital, in middle of the neck, this is called transcervical. This is called transcervical. Lowermost portion of the neck, with beginning of the trochanteric area, this is called basicervical. Basicervical comparatively has a better prognosis. Okay, so this is anatomical classification of fracture neck of femur. Coming to Powell's classification, first you should know what is a Powell's angle. Powell's angle, when you draw a horizontal line, okay, just you please closely watch here. This is the fracture line. This is the fracture line. This is the fracture line. You are drawing a horizontal line. You are drawing a horizontal line to the fracture line. The angle between the horizontal line and the fracture line is called Powell's angle. This angle is called Powell's angle. Okay, I repeat once again, dear friends, concentrate because this is the initiate question. This is the AIMS question. Powell's angle. Angle formed between the horizontal line and the fracture line is called Powell's angle. This is called Powell's angle. When Powell's angle is less than 30 degree, it is called type 1. When Powell's angle, you see you are drawing a horizontal line. When Powell's angle is between 50, if Powell's angle is less than 50, it is called type 2. Okay, that is 30 to 50. It should take like this. 30 to 50 is called type 2. And you are drawing a horizontal. Powell's angle is more than 70. It is called type 3. It is called type 3. So Powell's type 1, type 2, type 3. So obviously, which should have a better prognosis? One should have a better prognosis. Gordon's classification. Fracture is incomplete. Fracture is incomplete. Trabecular pattern is okay. Normal. Fracture is complete but totally undisplaced. Trabecular pattern is normal. This is type 1, type 2. Type 3. Fracture is complete, partial displacement. One cortex is okay, another cortex is displaced. See, the trabecular pattern is altered. Type 3. When the fracture is complete and totally displaced, it is type 4. This has the worst prognosis. This has the worst prognosis. And once they had asked in AIMS, all these classification system, what you are seeing now, anatomical classification, broad classification, Powell's classification, Gordon's classification, all these things are for adults. This won't, the Gordon's classification will not suit a child. So the classification system for children, those who are having fracture neck of femur. Dear friends, I am telling you a point, fracture neck of femur is common problem of elderly. Very, very rarely, once in a blue moon, you can get fracture neck of femur in a child. The classification system name alone, please remember Delbet. Okay, Delbet classification is for children. The classical presentation of fracture neck of femur is, when you look at the patient, the affected side limb will be shortened, number 1. Number 2, externally rotated. Okay, hip is the affected limb seems to be shortened, externally rotated. Okay, when you press over that, there will be tenderness in the anterior joint line. Anterior joint line and all, no need to explain. You should be, what is anterior joint line, where this anterior joint line is situated, all these things I hope you know. For my completion, just in a second I will tell you. You just palpate the anterosuperior iliac spine, you palpate the pubic symphysis. Midpoint is called midinguinal point. You mark the midinguinal point. 1.5 centimeter below and lateral to midinguinal point is the anterior joint line. Okay, it is 1.5 centimeter below and lateral to mid-inguinal point. Okay, it is called anterior joint line. So whenever there is anterior joint line tenderness, 100% states it's a hip pathology. And taking into X-ray, when you take X-ray pelvis with both hips AP, it will show a very classical thing. You can see the fracture neck, the fracture pattern you can see. Apart from that, the great question, breakage of Shenton's line is very characteristic. Okay, breakage of Shenton's line. What is normal Shenton's line? Okay, what is normal Shenton's line? Shenton's line, it is the line drawn from superior margin of the obturator foramen to the margin of the neck. Superior margin of the, you look at this diagram. This is the normal thing. This is the superior margin of the obturator foramen to the neck. It forms a smooth curve like this. This is normal. Here fracture neck of femur has happened in this patient. This is a fracture. So from superior joint line, when I try to connect, no, it is not giving a smooth curve. It is broken. It is disrupted. Shenton's line. Look at that real X-ray of one of our patient. You see fracture neck is here. Head has submerged here. So from superior margin of the obturator foramen, when I draw a line, you see how it is happening. It is broken. It is broken. Normally how it should be, if it is a normal, there is no fracture neck of femur, it should come like this. It should come like this. Okay, so this is called breakage of Shenton's line. Okay, whenever you come across, dear friends, in radiology or in orthopedics, breakage of Shenton lines, differential diagnosis, fracture neck of femur, posterior dislocation hip, congenital dislocation hip. Okay, so what are the three important causes for breakage of Shenton's line? Fracture neck of femur, posterior dislocation hip, congenital dislocation hip. In these three situations, there will be breakage of Shenton's line. So they will ask a question in AIMS like this: all are causes of breakage of Shenton's lines except. So what are the three differential diagnoses? Fracture neck of femur, posterior dislocation hip, congenital dislocation hip. Treatment of fracture neck of femur is essentially surgery. 100% it should be operated because it will never heal naturally. 100% it needs surgery. And fracture neck of femur is an orthopedic emergency. And the best thing, timing is it should be fixed within 24 hours. Okay, 24 hours. So this treatment, no, this is the most important slide. As far as fracture neck of femur is there, when we complete this slide, everything is okay. Treatment of choice is according to two important things. One is Gordon's classification. Number two, age group. Number two, age group. Two things we are taking together and we are arriving at what is the best treatment plan. 1 lakh time repeated MCQ in AIMS exam. They will give you 65-year-old female. So they will give age and the Gordon's type. Please concentrate. Everyone knows what is Gordon's type 1, type 2, type 3, type 4. For revision sake, Gordon's type 1 incomplete, type 2 complete, undisplaced, type 3 complete, partially displaced, type 4 complete, totally displaced. These are the 4 Gordon's type. If it is Gordon's type 1, you are giving a hip spica. Spica means it is POP, immobilizing the hip spica. Okay, if it's a child, fix it with an Austin Moore pin or Novel screw. Nothing. So Gordon's type 1 can be managed, tried, can be, because the fracture is incomplete, no? So still there is a high chance that the neck will unite and blood supply, everything will be well maintained because it's incomplete. So you are trying a conservative management, type 1. Gordon's type 2 means fracture is complete, but it is undisplaced. So let us try to preserve the original head. Why to replace it? So Gordon's type 2 is complete but is undisplaced. So what I am trying to do is, for example, just take, this is greater trochanter, this is neck, this is your head, this is a lesser trochanter, this is lesser trochanter and the shaft. This is greater trochanter and here is the shaft is coming like this. Just imagine this is your GT, LT, neck, head like this. A fracture has happened, Gordon's type 2. A fracture has happened in the neck, but it is undisplaced. Why I should remove this and try to replace? I try to preserve this head by putting a screw here, okay, a screw, and fixing the screw with a plate in the shaft of the femur. This is called dynamic hip screw, DHS. So, for Gordon's type 2, the treatment of choice is dynamic hip screw. Dynamic hip screw. If it is Gordon's type 3 or type 4, what is type 3? Complete fracture, partially displaced. Type 4, complete fracture, totally displaced. So, in that situation, you cannot save, you cannot preserve the original head. So, go for replacement of the head and neck. That is called prosthetic replacement. That's called joint replacement. That's called arthroplasty. That is called arthroplasty. Arthroplasty means joint replacement. Joint replacement is again of two types. Okay, joint replacement is again of two types. Okay, so arthroplasty is divided into hemiarthroplasty, total hip replacement. Arthroplasty is again divided into two types, a hemiarthroplasty or a total hip replacement. Hemiarthroplasty means I am replacing only the head and neck. I am not replacing the acetabulum. Acetabulum is patient's original acetabulum. We are replacing only the head and neck. That is called hemiarthroplasty. Total hip replacement means I am replacing the acetabulum, I am replacing the head and neck. That's called total hip replacement. Okay, so Gordon's type 1 conservative, Gordon's type 2 DHS, Gordon's type 3 arthroplasty, Gordon's type 4 arthroplasty. So arthroplasty is of hemi and total. Now we are going to see in which case you should go for hemi, which case you should go for total hip replacement. That I will teach you. Okay. So if the age group is 70 years and above, it is undisplaced. Undisplaced means DHS first. It is totally displaced. That is Gordon's type 3, type 4, age is 70. Directly total hip replacement. Directly total hip replacement. If it's a young adult, for example, his age is 35, 36, 37, 40, something like that, up to 40. As a young adult, 35. Undisplaced, you do a dynamic hip screw. Even if it is displaced, try to reduce and try a dynamic hip screw. Wait for 3 months. You see whether the head is taking up the blood supply. If the head takes up the blood supply, leave it with a dynamic hip screw. If even after 3 months it's showing signs of non-union and avascular necrosis of head or femur, no problem. Remove the DHS, replace it with joint replacement, arthroplasty. If it is a child means undisplaced, again hip spica, conservative, POP, Austin Moore spinning. Even if it is displaced, if it's a child, you cannot do replacement because it's a growing bone. Just allow the child to play, just to have a natural course till skeletal maturity. After skeletal maturity, once the child becomes an adult, you do a corrective osteotomy later. Okay, this is how we should approach a case of fractured neck of femur. Now I will tell you where to do hemiarthroplasty, where to do THR. If the patient is very old, 70 years, directly anyhow you can do a THR. But the problem is 60 years and all, in borderline cases, you will be doubting where to go for hemi, where to go for THR. It depends upon the status of the acetabulum. Status of the acetabulum. If the acetabulum is fine, acetabulum is pakka normal, it is normal, there is no damage, there is no degenerative changes, nothing. Acetabulum is completely normal, go for hemiarthroplasty. If acetabulum is also damaged, no other go, you have to go for total hip replacement. Why I am telling this, dear friends? If acetabulum is normal, when you are replacing the head alone, patient starts walking, nothing will happen. If acetabulum is damaged, no, when you replace the head and neck alone, acetabulum, the original acetabulum is there, patient start asking, it will cause severe pain. The very aim of doing arthroplasty joint replacement is painless mobile life. The motto of arthroplasty is pain-free mobile life. So the patient is moving but with a lot of pain. What is the use of joint replacement? So whenever there is acetabular pathology, when there is acetabular damage, you have to straight away go for total hip replacement. Okay. And look at these two processes because very recently asked image based question. This is a hemiarthroplasty prosthesis. This is also a hemiarthroplasty prosthesis. Look at here. I am able to see a part here, head, small neck. Okay, this is called calcar. The small neck, this is called calcar. And few holes are here. They are called fenestrations. They are called fenestrations. In this prosthesis, hemiarthroplasty prosthesis, I am able to see a head, a neck and a stem. In the stem, I am seeing two holes. They are called fenestrations. This prosthesis is called Austin-Moore. This prosthesis is called Austin-Moore's prosthesis. Okay, Austin-Moore. Here, I am seeing head. Okay, directly the stem. Directly the stem. I am not seeing any fenestration. So this is called Thompson's prosthesis. Okay, this is called Thompson's prosthesis. Got me? So this is an image based question. Okay, again we can expect the same question. They are giving an image like this. A fenestrations are there, a small neck is there. This is Austin-Moore. This is Austin-Moore. Without this neck, it is called calcar. This is called, the technical term is calcar. A prosthesis with a calcar and a fenestration is Austin-Moore. Prosthesis without a calcar and without fenestration is called Thompson's. It's called Thompson's. Okay, right. Then the complications, already I had finished the complications of fracture neck of femur. Already told you. Most common complication is non-union avascular necrosis. Second common complication is thromboembolism. Book says thromboembolism can happen up to 40%. Okay. So we have finished fracture neck of femur. We are going for the next topic, hip dislocations. Hip dislocations is of three types. Posterior, anterior, central. Most common type is posterior dislocation, hip. And most common type, it is posterior dislocation. Posterior dislocation, you see, what is the mode of injury? Patient will be sitting in a car in the front seat without wearing a seat belt. Axial force applied to a flexed, adducted, internally rotated hip. You are sitting in front seat like this. Flexion, adduction, internal rotation. Knee goes and dash against the dashboard. Posterior dislocation happens. So it's called dashboard injury. That's called a dashboard injury. That is a significance, no? Why to wear a seat belt? So, what is the position of posterior dislocation of the hip? Hip is flexed, adducted, and see, internally rotated. So, what is the attitude? Flexion, adduction, internal rotation. If it is flexion, abduction, external rotation, that is anterior dislocation hip. Okay. So, flexion, adduction, internal rotation. Marked shortening of the limb with gross restriction of hip movements. There will be vascular sign of Noreth. Vascular sign of Noreth. What do you mean by vascular sign of Noreth? Only once I will explain. Please look at me. See, you are palpating the femoral artery pulsation. Okay, you are palpating the femoral artery. Femoral artery is seen in mid-inguinal point. Femoral artery pulsation on both sides. Normally, easily palpable femoral artery will be there in all of us. If femoral artery is not palpable or very feeble, that is called positive vascular sign of Noreth. Why this is happening? Just below the femoral artery or behind the femoral artery, a bony support is always there, and that bony support is neck and head and neck. If that bony support is not there, when you press with your thumb, if there is no underlying bony support, femoral artery, the vessel will go down. You can't palpate that easily. So you can't palpate a pulse, or very feebly you will palpate a pulse. Then it's called positive vascular sign of Noreth. Whenever you get positive vascular sign of Noreth, number 1 DD fracture neck of femur, number 2 DD posterior dislocation hip, number 3 differential diagnosis congenital dislocation hip, number 4 Tom Smith's arthritis, number 5 excision, girdle stones excision arthroplasty. Okay, I will write for your sake everything I had discussed very detailed in the main video. Please, I'll repeat once again because this is such an important question. Vascular sign of Noreth is seen in, okay, fracture neck of femur, posterior dislocation hip, congenital dislocation hip, Tom Smith arthritis, okay, girdle stones, girdle stones excision arthroplasty. Girdle stones excision arthroplasty. Okay, girdle stones excision arthroplasty comes under the chapter tuberculosis of the hip. Whenever there is tuberculosis of hip not getting resolved with your routine anti-tuberculous drug, excise the head and neck of femur. That's called girdle stones excision arthroplasty. Okay, 50% of the posterior dislocation hip is associated with posterior chip fracture of the acetabulum. CT scan is the investigation of choice in dislocation with fractures. Why I am telling X-ray is a very good investigation. CT is better than X-ray. Why I am telling? Most of the hip dislocations are associated with acetabular fracture. Simple X-ray, we may miss a fracture. Okay. If you use a CT scan, we will never miss anything. That's why CT is, suppose in your MCQ, investigation of choice for dislocation hip, CT scan is there. Tick CT scan. Okay. Yes. A very practical way to differentiate posterior dislocation hip from anterior dislocation hip by X-ray is that when the head is larger, it is ADH, anterior dislocation hip. When head is smaller, that is posterior dislocation hip. You see here, see, this is an X-ray. Normally, so this is your superior margin of the obturator foramen. Okay, so here should be, this outline is your acetabulum. Normally, head should sit here. This is normal. This is normal. What happened in hip dislocation? It has gone high above posterior. You see in a real X-ray, this is your acetabulum. So what happened? The head has overridden and it is behind the acetabulum. So only a part of head is seen. The next part is behind the pelvis. Yes or no? So head appears smaller or not? Head appears very smaller. So this is posterior dislocation hip. This is posterior dislocation hip. In posterior dislocation hip also, you can see when you draw the sentence line, it is not connecting. Totally broken. Okay. Normally it should come like this, no? Should come like this. Head and neck is not there. So it is broken. Sentence line is broken. The classification for posterior dislocation hip is called Thompson and Epstein. I am expecting this question for the past 2 years. I am expecting because all other classification they had asked. Okay, so Thompson and Epstein's classification. Type 1 dislocation without fracture. Pure posterior dislocation hip, no fracture. Type 2 posterior dislocation hip with a single chip fracture of the posterior acetabulum rim. Posterior acetabular rim. Single chip fracture of the posterior acetabular rim. Type 3 is dislocation with the comminuted fracture of the posterior acetabular rim. Type 4 is dislocation with the fracture acetabular floor. In type 2 and type 3, it is acetabular rim. In type 4, it is acetabular floor. Type 5, posterior dislocation hip associated with fracture head of the femur, femoral head. This has very bad prognosis. Very bad prognosis. Okay. So Thompson and Epstein's classification is very simple. Type 1, it is dislocation without fracture. Type 2, dislocation with a chip fracture of the acetabular rim. Type 3, dislocation with comminuted fracture acetabular rim. Type 4, it is dislocation with a fracture of acetabular floor. Type 5, it is dislocation with femoral head fracture. So this is the diagram. Kindly go through. Usually the treatment is close reduction tried under anesthesia. Ideally it should be reduced within 6 to 12 hours. Just the reduction technique name: Stimson's gravity method, Alice traction method, Bigelow's method, classical Watson-Jones method. This is very widely used method. Classical Watson-Jones method, East Baltimore technique. East Baltimore, a place, no? East Baltimore technique. After reduction, hip is immobilized in Thomas splint for 3 weeks. Full weight bearing is allowed after 6 weeks. So this is Stimson's gravity method. This is Alice method. This is the classical Watson-Jones method, where you are flexing and you are lifting. And the complications, most common nerve that is involved in posterior dislocation hip is sciatic nerve, 1 lakh time repeated MCQ. The two common peroneal. So the patient will present to you with foot drop. Okay, foot drop. That will be the presentation. Most common vessel involved is superior gluteal artery. Posterior dislocation hip are notorious to go for myositis ossificans. Traumatic osteoarthritis due to avascular necrosis of head of femur can happen. Posterior dislocation hip is not reduced properly. It can go for recurrent dislocation. Anterior dislocation is very, very rare. Mechanism of injury, forced abduction and lateral rotation of hip. So it happens in air crash. Okay, usually happen violent or TR air crash. Clinically, the apparent limb lengthening will be there. Hip is flexed, abducted, externally rotated. In anterior dislocation hip, there won't be vascular sign of Norath. A vascular sign of Norath is absent or negative in ADH. Vascular sign of Norath is positive in PDH. Okay. So ADH, most common nerve involved is femoral nerve. There it was sciatic nerve, here it is femoral nerve. Vascular is negative, I told you. Central dislocation hip, I told you that the rarest possible type central dislocation. What happens? There will be fracture of the acetabulum and head will enter into the acetabulum into the pelvic cavity. That's called central dislocation. One peculiar thing, when you do perirectal examination, you will be able to palpate the head of the femur. Then the diagnosis is central dislocation hip. The classification system for anterior dislocation, for posterior dislocation is Thompson and Epstein. Here it's only Epstein. Type 1, type 2. Superior dislocation, type 2 is inferior dislocation. Superior dislocation is called pubic type. Inferior dislocation is called obturator type. Okay. Right. Coming to the next topic, dear friends, fracture patella. Again, very frequently asked image-based area, fracture patella. Patella is the largest sesamoid bone. Mechanism of injury, direct trauma. Patient will be walking, suddenly will stumble, directly patella go and just it goes and touches the ground. It is gone. So direct trauma, most common cause. It produces comminuted fracture patella. Indirect trauma. How indirect trauma? Violent contraction of quadriceps femoris can cause fracture patella. For example, you are walking, you are not noticed a big pit is there. Without knowing, you have put your foot on the pit. What happened? Violent contraction of the quadriceps happen. Patellar tendon is pulled and the quadriceps tendon is pulled and the patella will go for a transverse fracture patella. So these are the two mechanisms: direct trauma, indirect trauma. Direct trauma is the most common mechanism. Indirect trauma is due to violent pull by the quadriceps. Patellar fracture is divided into undisplaced, displaced. What is the undisplaced, displaced? It is the gap when the gap is 1 to 2 mm, less than 2 mm. Okay, when the gap is less than 2 mm, then it is undisplaced. When the gap is more than 2 mm, it is displaced. So displaced fracture patella, the classification, it is divided into, according to the fracture pattern, transverse type, oblique type, vertical type, comminuted type. Most common type is transverse fracture patella, 85%. The second common type is comminuted fracture patella. These two things you should know. The best X-ray view of patella, AP lateral is a routine view which we do in our OP, but that's not enough. The best view is skyline view, otherwise called axial view, is the view of choice. Skyline view, otherwise called axial view, is the view of choice. You look at here how this axial view, skyline view is taken. Patient is put in a prone position. The cassette, the film is here. Beam is passing from here. It's covering the patella. You will get an image like this. Okay, you will get an image. You see the whole patella you are seeing. Femoral condyle, and you can see the whole patella. You can't miss a single thing in this view. So this is called skyline view, otherwise called axial view. This is the investigation of choice or view of choice for fracture patella. So see the undisplaced less than 2 mm and displaced more than 2 mm. Comminuted, these are the fracture types. And for the treatment of choice for fracture patella, undisplaced fracture patella, if displacement is less than 1 to 2, I told you already, the treatment of choice is cylindrical cast, tube cast or cylindrical cast. You are putting a POP, making the knee straight, putting a POP from middle of the thigh to middle of the leg. You are covering with a plaster of Paris cast. Leave it for 45 days. That is the treatment of choice. So, undisplaced fracture patella, treatment of choice, conservative. Manage with a POP, conservative. Okay. If it is displaced more than 2 mm displacement is there, surgery is the treatment of choice. And transverse fracture patella, it is called tension band wiring. Okay, tension band wiring is the treatment of choice. For a displaced fracture patella, the treatment of choice is tension band wiring. You see here, so this is the patella. Just I put a 2 K wires, and these 2 K wires are with a like this. So this is called a tension band wiring. This is called tension band wiring. So this is the treatment of choice. The full name of that is Martin circumferential tension band wiring. And highly comminuted fracture patella. You can't do tension band, thrown into many small fragments. You cannot reconstruct it. Only thing what you have to do is called a patelectomy. You have to remove the patella. It's called patelectomy. When you remove the patella, what is the only complication you can expect? Patient can walk normally, can climb the stairs, can climb down the stairs, can squat, can sit cross-legged, everything they can do. Last 10-degree extension is not possible. That's all. That's the only complication. Last 10-degree extension is not possible. That's called extensor lag. The only complication of patelectomy is extensor lag. Then comes to the next topic, recurrent dislocation patella. In recurrent dislocation patella, I told you the most common dislocation of shoulder is anterior. Most common dislocation of hip is posterior. Most common dislocation of elbow is posterolateral. And the most common type of patellar dislocation is lateral. Patellar dislocation is lateral. So, when it very frequently the patella gets displaced on lateral side, dislocated on lateral side, is called recurrent dislocation patella. Every time when you flex and extend, the patella is going to lateral side. That's called habitual dislocation. There is no treatment for habitual dislocation. No need to treat a habitual. But there are treatments available for recurrent dislocation patella. When somebody is going for recurrent dislocation patella, what are the predisposing factors? What are the causes? Number one cause, abnormally high-lying patella. That is called patella alta. Abnormally high-lying patella. Patella alta. Number two cause, abnormally low-lying patella. That is called patella B-A-J-A. Pronounced as Baya. Not Baja, Baya. Okay, patella baya. Number 3, genu valgum. Number 4, genu recurvatum. Number 5, tight lateral structures. These are the causes. When somebody is developing recurrent dislocation patella, these causes should be ruled out. These predisposing factors should be ruled out. Okay. So, tight lateral structures. What do you mean by tight lateral structures? What are these lateral structures? Iliotibial band. Okay, iliotibial band. Iliotibial band, when it gets contracted, tight lateral structures. I'll tell you now, the side by side, I'll tell you what are the important causes for iliotibial band contracture. Poliomyelitis. Iliotibial band contraction. Poliomyelitis is an important cause for iliotibial band contracture. So these are the causes. What are the predisposing factor? Ames' favorite question. Patella alta, patella baya, genu valgum, genu recurvatum, tight lateral structures. Okay. Then in X-ray, to rule out patella alta and patella baya, abnormally high-lying patella, abnormally low-lying patella, you have to do a thing called in X-ray, what is called Blumen-Sat line. Frequently asked MCQ. Blumen-Sat line. What do you mean by Blumen-Sat line? Just you draw, these are the condyles, no? Femoral condyles. This is called roof of the condyle. This is called roof of the condyle. Normally speaking, lowermost portion of the patella should come and just touch the roof of the, this is normal. This is normal. When patella, this is the roof of the condyle. When the lower pole of patella is very much above the roof of the condyle, patella alta. Patella alta. Other way around. Okay. When the lowermost portion is very much below the roof of the condyle, this is called patella baya. Both are abnormal, both should not be there in the X-ray. So in this X-ray, see, this is the roof of the condyle, okay, but the patella is not in its original position. It is not in original position, very much laterally shifted. So very classical X-ray of lateral dislocated patella. So this is called Blumen-Sat line. Another important line is there. Kindly read if you are interested. Insol-Salvetti ratio. Okay. Insol-Salvetti's ratio. It is the ratio between length of patellar tendon to the patella. Normally it should be 1. If it is altered, high chance it can go for. The treatment of recurrent dislocation patella is called Campbell's operation. Campbell's operation. Campbell's operation is, it is wrongly typed here, don't follow. Campbell's operation is just lateral release. Campbell's operation is lateral tight structures are there. No, you are cutting the lateral tight structures. That's called modified Campbell's procedure. Roux and Goldwaite procedure is proximal realignment of the capsule of the knee. Western Soto Hall means only if patella is there, it is going for recurrent dislocation. No, remove the patella. Patelectomy is called Western Soto Hall's technique. Western Soto Hall's technique. Yes. Then coming to the metatarsal fractures. Important fractures, only two fractures. One is called Jones fracture and one is called March fracture. What do you mean by Jones fracture? Fracture of the diaphysis of fifth metatarsal. Look at the point. It is fracture diaphysis of the fifth metatarsal, 1.5 centimeter above tip of the tuberosity. It is an avulsion fracture due to pull of peroneus brevis muscle. Okay, so Jones fracture treatment is BK slab, but many times if it's totally displaced, it needs K-wire fixation. K-wire fixation. Okay, March fracture. Stress or fatigue fracture of the metatarsal, particularly second metatarsal, is called March fracture. It is common in policeman. I told you already in fracture classification, March fracture is otherwise called stress fracture, otherwise called fatigue fracture. Okay, so common in policeman, military personnel. Treatment is just bed rest and NSAIDs. Look at these diagrams. You see classical Jones. This is tuberosity, 1.5 centimeter above the tuberosity. This is called, a Jones fracture. This is very close, pseudo Jones fracture. This is a March fracture. This is called, the tuberosity tip is avulsed, no? This is called dancer's fracture. This is called dancer. This is called a dancer's fracture. Right? Image based MCQs. This is called a pseudo Jones, not original Jones. Pseudo Jones. This is a Jones, classical Jones. This is classical March. Okay? Please register this in your mind. The exact question may come in our exam. Okay? So, dancer's fracture, because ballet dancer used to develop this. Dancer's fracture, pseudo Jones fracture, March fracture. Okay? So, that completes the metatarsal fractures. I'll move on to the next topic. Myositis ossificans. Again, a very important area. First of all, you should know the definition of myositis ossificans. Myositis ossificans is otherwise called heterotrophic ossification, otherwise called ectopic ossification. So, what's the definition? Ossification happening in unwanted site is called myositis ossificans. Normally, ossification should happen either enchondrally. Ossification should happen, otherwise membranously. Okay, these are the two types. Okay, membranous ossification or enchondral ossification. Here, ossification is happening in unwanted sites or ectopic sites. That is called myositis ossificans, otherwise called heterotrophic ossification. As the name implies, the next thing, what are the four structures that are involved in myositis ossificans? Where, in which unwanted site ossification is happening? So that's what. Number one, it's happening in muscle. The word myo, muscle. Second site, tendon. Third site, fascia. Fourth type, periosteum. Okay. So, myositis ossificans means ossification happening in muscle, tendon, fascia, periosteum. Last but not the least, that periosteum is very important, because that's what I will tell you in clinical feature as well as radiologically, the involvement of periosteum confuses myositis with another important condition. That's the differential diagnosis that I'll tell you. Most common cause of myositis ossificans is ill-advised massage. Who will do that? Native or traditional bone setters. Native treatment or traditional bone setters. Ill-advised massage. Okay, it's the most common cause in general. Myositis ossificans. Ossification happening in ectopic or unwanted sites. Muscle, tendon, fascia, periosteum. The most common site of myositis ossificans is around elbow joint. This is the most common site. It can happen anywhere. Myositis most common site is elbow joint. And the clinical features, what are the clinical features of myositis ossificans? Number one, pain, severe pain. Number two, swelling. Number three, there will be increased temperature and the swelling will be bony hard. Okay, bony hard. And restriction of joint movements. Okay, so these are the clinical signs, clinical features. The differential diagnosis for myositis ossificans is okay, it's a very notorious condition, dangerous condition, osteogenic sarcoma. How many times? Osteogenic sarcoma. Okay, so this is the main differential diagnosis of myositis ossificans. Okay, and I am telling you, dear friends, practically speaking, clinically, radiologically, it's very difficult to differentiate myositis ossificans from osteogenic sarcoma. Myositis will have a bony mass. Osteogenic sarcoma will have a bony mass. Myositis have severe pain. Osteogenic sarcoma will have severe pain. Myositis ossificans common around joint. Osteogenic sarcoma common around joints. Radiologically, when you take an X-ray, what happens? No. See, what are the structures that are involved in myositis ossificans? Muscle, tendon, fascia, periosteum. So periosteum is involved. So it's caused periosteal reaction. So elevation of periosteum happens in myositis ossificans. Osteogenic sarcoma, the finding is periosteal elevation, which is called Codman's tumor. Again, I'll teach you when I come to osteogenic sarcoma topic. I'll touch this point again. So that is the main differential diagnosis. So how to confirm the X-ray? No. When you take an X-ray, you see this is an X-ray of elbow joint. You see this is humerus. This is your radius, right? This is ulna. So you are able to see this is radial head, humerus, ulna. Okay, you are able to see some fluffy bony mass here, no? Bony mass is seen. Able to see, that is myositis ossificans. That is myositis ossificans. Most common, it's around elbow joint, especially over the brachialis tendon. 1 lakh time repeated question. Most common site, brachialis tendon. This is the most common site of myositis ossificans. Confirmation is always by biopsy. It will show you the classical Ackermann zones phenomena. Ackermann zones phenomena. What do you mean by Ackermann zones phenomena? It is a 3-layered zone phenomena. Okay. When it is a case of myositis ossificans, it gets divided into 3 layers. First layer, second layer, third layer. Okay, 3 layers like a target. Innermost layer is cellular layer. Cells. Cellular layer. Innermost microcells will be there. The next layer, it is a layer of fibroelastic tissue. Fibroelastic tissue. Outermost layer constitute a mature, well-oriented bone. Mature, well-oriented bone. Mature, well-oriented bone. Okay, so the innermost layer is highly cellular layer. Next layer is a layer of fibroelastic tissue. Outermost layer is a matured, well-oriented bone. These 3-layered phenomena is called, okay, Ackermann zones phenomena. When you see Ackermann's zones, when you take a cut section of this and it shows the innermost cellular layer surrounded by fibroelastic tissue, outermost layer is by matured, well-oriented bone. Diagnosis is confirmed, it is myositis ossificans. It is not osteogenic sarcoma. So they may ask this question. Ackermann zones phenomena is seen in myositis ossificans. Otherwise, they can give this as a picture. They may ask you, what is this? Okay. Yes. Treatment. Coming to treatment of myositis ossificans, the main treatment is rest, immobilization. Immobilization. First of all, elbow, immobilize. How long we will immobilize? 6 to 8 weeks till the myositis mass gets matured. Meantime, the drug of choice is indomethacin. Indomethacin. Then aptly uses a word theoretically, give a shot of radiation. Radiation. Finally, once the mass gets matured and it gets well circumscribed, well formed, the treatment of choice is surgical excision. Surgical excision. Okay. So whenever you get a case of active myositis, just immobilize. Don't move, immobilize. When you move, it will become diffuse, it won't settle. So immobilize till the mass is matured. Give indomethacin, non-steroidal anti-inflammatory drug. The drug of choice is indomethacin. Then gives radiotherapy. The book says aptly stresses this point. Why it stresses? When you give a shot of radiotherapy, when you excise the mass, recurrence rate is less. So radiotherapy. Okay. Radiotherapy. Finally, surgical excision. This is the treatment of choice. Excision is the treatment of choice, but you can't do it all of a sudden. You should allow the mass to mature. This will take 6 to 8 weeks minimum. Okay, 8 weeks minimum. Okay, good. And be careful. So far, what we had seen is called myositis ossificans. So myositis ossificans is divided into two types broadly. Myositis ossificans traumatica. Myositis ossificans is divided into myositis ossificans traumatica. So far what we had seen is because of ill-advised massage and traumatica. Another is called myositis ossificans progressiva. Myositis ossificans progressiva. So myositis is divided into myositis ossificans traumatica, myositis ossificans progressiva. You should know myositis ossificans progressiva is entirely different because that is a congenital condition. Number one. The most common muscle that is involved is brachialis here. Here it usually starts in the region of trapezius. Then it goes to latissimus dorsi. Go finally involve all the joints including the ribcage joint. Patient can't breathe, patient will die. Since it's a congenital condition, it's associated with two important associations. Microdactyly, number two, Klippel-Feil syndrome. Klippel-Feil syndrome is congenitally fused cervical vertebra. All the 7 cervical vertebra made into one single vertebra. Klippel-Feil syndrome. So whenever a word Klippel-Feil syndrome comes in orthopedics, okay, congenitally fused cervical vertebra, Klippel-Feil syndrome is associated with two things in orthopedics. Myositis ossificans progressiva. Another is sprungle shoulder. Sprungle shoulder. Two things it's associated with sprungle shoulder. Okay, and patient usually dies of intercurrent infection. Okay, because respiratory infection, the muscle, everything is invaded by this myositis and they will usually die of respiratory failure, respiratory infection. So there is no definitive curative treatment for this condition. Bisphosphonates are tried. Bisphosphonates, it is alendronate, pamidronate, chlorodronate, zolindronic acid. These are bisphosphonates. Bisphosphonates are tried in osteoporosis. Bisphosphonate given in Paget's disease. Okay, so the bisphosphonates, if at all you want to try a drug, try bisphosphonates, but there is no curative. Prognosis very bad. Okay, so myositis ossificans traumatica will not cause mortality, only morbidity. Myositis ossificans progressiva will cause mortality. That's the difference. Okay, then coming to next important topic, ARDS, other is called fat embolism. ARDS is other is called fat embolism. Okay, fat embolism. The classical usual manifestation is 48 hours. Usual manifestation is 48 hours. And the most common cause of fat embolism in an adult is, young adults, is fracture of long bone, especially shaft of femur. Shaft of femur fracture is the most common cause in young adults. Pelvic fracture is the most common cause in elderly, because what is the mechanism of fat embolism? When a bone is shattered, damaged, bone has bone marrow. Okay, the cancellous bone has bone marrow. So when the bone is very much damaged, the direct fat globules, okay, so directly from the bone marrow fat, direct source, bone marrow has fat globules. That fat globules enter circulation, causes embolism. This is the mechanism, only proven mechanism. Other two things are high. Okay, the cancellous bone has bone marrow. So when the bone is very much damaged, the direct fat globules, okay, so directly from the bone marrow fat, direct source, bone marrow has fat globules. That fat globules enter circulation, causes embolism. This is the mechanism proven, especially iliac crust, which will be having the marrow and marrow fat. That is why most common cause of fat embolism in young adult is fracture shaft of femur. most common cause of fat embolism in elderly is pelvic fracture. Okay. Yes. The Savitz clinical criteria says usual onset is 24 to 48 hours. Patient will have tachycardia. Patient will have pyrexia. Lower conjunctival petechia is pathognomonic. Guaranteed in an exam like our NEET, NEXT and INISET, you can expect a question like this. Patient, young adult, developed a violent RTA. 3 days later, he developed tachypnea. On examination, having petechial hemorrhage in the lower conjunctiva. Diagnosis, fat embolism. Otherwise called ARDS. ARDS is otherwise called acute respiratory distress syndrome, adult respiratory distress syndrome, shock lung, traumatic wet lung, fat embolism. 5 synonyms are given in Robbins. Okay. So, this is pathognomonic, and you should know what do you mean by GERD criteria. It is a triad of symptoms. Okay. GERD criteria. Number 1, hypoxia. Number 2, mental confusion. Number 3, petechial hemorrhage. Petechial hemorrhage, especially lower conjunctival. So this is called GERD's criteria. We can expect this as a new question, so far unasked in any of the entrances. GERD criteria, triad of symptoms. Either they can ask this as GERD criteria or GERD's triad. Okay, GERD's triad. Both are same. GERD's criteria or GERD's triad. Okay, hypoxia, confusion, petechial hemorrhage, especially lower conjunctival. Then coming to investigation, X-ray shows, you look at this X-ray here, a haziness. This is called snowstorm appearance. Snowstorm appearance. Snowstorm appearance. Okay. So, snowstorm appearance. Oxygen saturation will go below 60. Platelet count, thrombocytopenia will be there. ECG shows a prominent S wave. Very peculiar. So far unasked in any of the entrances till now. ECG change of fat embolism. Prominent S wave. Okay. GERD test. This is a bedside test. 100% positive test. What is GERD test? You take 5 ml of patient's venous blood. You take a Merslin cloth, a dark color, jet black color Merslin cloth. Pour the venous blood over the cloth. Blood will get sedimented. With your naked eye, over the cloth, you can see minute micro golden yellow fat globules. Easily can see with our naked eye. That is called GERD test, which is a cost effective. No need to spend anything extra. You need a cloth. That's all. You just draw 5 ml of patient's venous blood, pour it, and you can see a golden color fat globule sheen over it. It is positive GERD test. Direct evidence of fat embolism. Okay. Yes. Coming to management, prevention is better than cure. Oxygen, hyperbaric oxygen, steroids, low molecular weight heparin, low molecular weight dextran, which is a plasma expander, antiplatelets. These can be tried. But most importantly, when it goes for severe hypoxemia, good ventilatory support. Ventilator. Okay. Ventilatory support. This is the main. Once upon a time, this carried a very bad prognosis. But with advent of latest ventilatory machines and good anesthetists, so easily we can revive these patients, fat embolism. But anyhow, prevention is better than cure. That's why how to prevent fat embolism. Thomas splint. For example, somebody has developed on the roadside violent road traffic accident, shaft of femur is there. Just like that, don't mobilize the patient. First you splint on the road. Then you shift the case. Okay, 90% of the problem you can prevent, fat embolism. Okay, yes. Coming to next important complication, Volkmann's ischemia. This is otherwise called compartment syndrome. Volkmann's ischemia is otherwise called compartment syndrome. Okay, compartment syndrome, Volkmann's ischemia. Yes. Elevation of the interstitial pressure in the closed osseofacial compartment that results in microvascular compromise and eventual contraction is called compartment syndrome or Volkmann's ischemia. So what is the normal compartmental pressure? 10 to 20 millimeter mercury. 10 to 20 millimeter mercury. That's a normal intracompartmental pressure. When any pressure goes beyond 20 millimeter, it is called raised intracompartmental pressure. That's called compartment syndrome, otherwise called Workman's ischemia. Most common site is volar aspect of the forearm, flexor aspect of the forearm. Second is anterior and deep compartment of the leg. Okay, rare sites are buttocks, shoulder, hand, foot and lumbar paraspinous muscle. Most common etiology in general is inappropriate tight bandaging. Inappropriate tight bandaging. When you put excessive tight bandage, that is the most common cause of compartment syndrome. And the fractures that predispose commonly are supracondylar fracture is the most common in children. Both bone forearm fracture is the most common cause in an adult. Okay, compartment syndrome usually happens here, right? The muscles, the first muscle, several times repeated MCQ, gold standard MCQ, the most common muscle or first muscle to be involved is flexor digitorum profundus. FDP is the first muscle to be involved. Okay, first muscle to be FDP, right? The other important muscles that are involved are flexor pollicis longus, flexor digitorum superficialis, then comes wrist flexors, then lastly thumb flexors. Okay, thumb flexors. If it involves only flexor digitorum profundus, this is called in Suge, the classification TSUGE, Suge's classification. T is silent, pronounced that as Suge, Suge's classification. So, if it involves only FDP, it is called Suge's type 1. Type 1. Okay, Suge's type 1. If it involves FDP, FPL and FDS, flexor digitorum profundus, flexor pollicis longus, flexor digitorum superficialis, it is called type 2. Suge's type 2. If it involves flexor digitorum profundus, flexor pollicis longus, flexor digitorum superficialis plus wrist flexors and thumb flexors, this is called type 3. So, how many types of Suges are there? Suges classification, type 1, type 2, type 3. Type 1 only FDP. Type 2 FDP, FPL, FDS. Type 3 FDP, FPL, FDS plus wrist flexors and thumb flexors. So, the worst type is type 3. In classical type 3 Suges, the classical sign is called Workman's sign. The classical sign is called Workman's sign. What is Workman's sign? Where wrist is flexed passively. Okay, see, Workman's ischemia, it will be like that. The patient can't, because it has undergone contracture. All the muscle had undergone ischemia, necrosis, fibrosis, contracture. So, everything is like that. So, wrist, when the wrist is flexed passively, this is the normal position in Workman's ischemia. Patient will come to you. When you flex the wrist passively, the fingers get extended automatically. When you leave it again, it will become like that. So, when you flex the wrist passively, wrist fingers get extended automatically. That is called Workman's sign. And Workman's sign is positive only in Suge's type 3. Coming to treatment, if it is a Workman's ischemia, that is compartment syndrome, early compartment syndrome, what are the clinical signs that you can expect? The earliest sign of Workman's ischemia, because I said the most common site is flexor aspect of the forearm. When you passively extend the fingers, severe pain along the flexor aspect of the forearm. This is called stretch pain. That is the earliest sign. That is the earliest sign. Second thing, when you palpate the pulse, it will become feeble or absent. That's a late sign. So that's a sign of ill omen. That means it's going from Workman's ischemia, it's going for necrosis and other complications. So earliest sign is stretch pain. So clinically, stretch pain is there, feeble pulse is there, you are suspecting Workman's ischemia. What you can do is, either you can confirm by measuring the pressure. There are special manometers are available. When you put a catheter inside the deep fascia, it connected to a manometer will show you. When the pressure is above 30, emergency fasciotomy is the treatment of choice. Emergency fasciotomy. So look at this diagram. Fasciotomy is not a heroic procedure, a house officer's procedure. Take a 22 blade, just cut the skin, superficial fascia and deep fascia. The pressure will be released. It's a limb-saving procedure. When you do it immediately, it's a limb-saving procedure. I'm telling you, emergency fasciotomy. Okay? But once an established Workman's ischemic contracture, that is, muscle is dead, necrosis happened, fibrosis happened, gone for fixed length phenomena, hand has become like this, then comes your Sioux classification. Whether it is type 1, type 2, type 3. Type 1 is called mild, type 2 is called moderate, type 3 is called severe. Mild means what I said, only FDP is involved. Treatment of choice is turnbuckle splint. Moderate, that is type 2, FDP, FPL, FDS. What is that? Just you are doing a soft tissue release. All the muscles that are attached to the extensor tendon, the flexor tendon muscles, the flexor tendon, the medial epicondyle, all the flexor muscles are attached to the medial epicondyle, FPL, FDS. Where are these muscles are attached? They are attached to the medial epicondyle. Just erase from the origin. Just cut from the origin. That is called Max Page procedure. It's called Max Page soft tissue sliding procedure. For moderate. Severe Sioux, apart from FPS, FDL and FDP, what happens? The wrist flexors and thumb flexors are also got involved. So the soft tissue procedure is not enough. You have to go for a bony procedure. What is a bony procedure? We have 8 carpal bones, and the carpal bones are divided into 2 rows. You are removing all the carpal bones that are present in the proximal row. That's called Sedan's carpectomy. That is the treatment of choice. That completes Volkmann's ischemia and Volkmann's ischemic contracture. We will move on to the next topic, CTEV, congenital talipes equinovarus. See, congenital talipes equinovarus is otherwise called clubfoot. Okay, it's called clubfoot. It's 50% bilateral, more common in boys. Polygenic inheritance. Many theories are there. I will tell you the most important thing. The most accepted is primary germplasm defect of the talus. That means there is a problem in formation of talus. So talus, congenitally, it's not formed, faulty formation of talus. So the size and shape of the talus alters. Since the size and shape of the talus is not maintained, it will go for congenital talonavicular dislocation. That is the pathology. Congenital talonavicular dislocation. So structural changes are more evident in the talus. To some extent, structural changes are seen in the calcaneum also. Okay. So clubfoot. You know what is the meaning of a club? Club means it is, okay, the golf, the end of the golf stick, this portion is called club. Exactly, that looks like that. So that's why it's called a club foot, right? And the 3 classical deformities are equinus at ankle, varus at subtalite joint, and adduction of the torso-metatarsal joint. So that this is called adduction of the torso-metatarsal joint, otherwise called forefoot adduction. Forefoot is torso-metatarsal area is forefoot, heel is the hind foot. So forefoot adduction, equinus, like a horse foot, equinus at the ankle, varus at subtalite joint. These are the 3 primary deformities of congenital talipes equinovarus. The most important thing, Ames aspect, common associations from Apley. Meningomyelocele, this is spina bifida. Okay, this is the common association. Spina bifida. Okay, this is the common association. Arthrogryposis multiplex congenita is a rare association. Tibial hemimelia means on one side of the leg tibia is absent. That's called tibial hemimelia. This is a rare association. Lateral popliteal nerve palsy, rare association. Poliomyelitis, in our country once upon a time, very common association. Cerebral palsy. So 6 points you should not forget. What are the associations of CTEV? CTEV associated with meningomyelocele, arthrogryposis multiplex congenita, tibial hemimelia, lateral popliteal nerve palsy, poliomyelitis, cerebral palsy. Okay, so these are the associations. Then how you are going to treat CTEV, congenital talipes equinovarus? CTEV should be treated as soon as this is wrong. Okay, as soon as birth, as soon as after birth. Okay, this is the right word. As soon as after the birth, immediately after the birth. CTEV. Okay, what is the thing they will do? They will manipulation by mother. That is the first treatment. Manipulation by mother. Okay, so forefoot, the order of correction, strictly we should follow the order. When we reverse the order or when we change the order, it will end up in a catastrophe. Forefoot adduction is corrected first, inversion is corrected next, equinus corrected last. This they had asked several times in the exam. Order of correction of CTEV. Forefoot adduction is corrected first, Inversion at subtalar joint is corrected. Second, equinus at ankle is corrected. Third, this is the order. When you reverse the order, it will end up in what is called a rocker bottom foot. Okay, it will end up in rocker bottom foot. Okay, so this is a complication. When you reverse the order, okay, you won't get the result, right? And how to treat, age-wise treatment plan is very important. Okay, you just categorize. 0 means at birth to 8 weeks. 8 weeks to 5 years. 5 years to 10 years. 10 years and above. 10 years and above. This is how you should classify age-wise treatment plan. This is the most important area as far as entrance is concerned. Okay. 0 to 8, from birth till 8 weeks, manipulation by mother. Manipulation by mother. Mother has to manipulate. An orthopedician or physiotherapist will teach the mother how to manipulate. Then after that, after correction, an orthopedician will put the baby on what? POP, that is called Ponseti's method. Ponseti's method. Okay, Ponseti's technique. So they will correct forefoot adduction first, inversion next, equinus lot. In the correct position, they will just give above elbow, above knee, POP cast, and that is called Ponseti's method. That is called Ponseti's method. 0 to 8 weeks. By 8 weeks, it should get corrected. Even after 8 weeks, after proper correction by an orthopedician by Ponseti's method, it is not getting corrected. It's called a refractory CTEV, and that should go for from 8 weeks to 5 years. You should go for soft tissue release. Okay, soft tissue release, surgical procedure. Okay, soft tissue release. Soft tissue release, what I'll do, the best soft tissue release is posteromedial soft tissue release, PMSTR, posteromedial soft tissue release. Posteromedial structures are released. Okay, there are 13 structures. No need to remember everything. Don't forget tendoachilles. Don't forget tibialis posterior. Okay, these two, the posteromedial structures are released. Because of that, they are having equinus at ankle, varus and subtaloid, forefoot adduction. So you are releasing the posteromedial structures. And this goes by a name. This is called Turcos procedure. Turcos procedure. They had asked this question. Turcos procedure. Okay. So Turcos procedure. Right. So 0 to 8 weeks, Ponseti's method, manipulation, conservative. Even after 8 weeks, it's not getting corrected. You should go for soft tissue release, posteromedial soft tissue release, which is called Turcos procedure. Even you are trying the soft tissue releases, and even after 5 years, you are not getting it corrected. Okay, so then after 5 years, your soft tissue procedure won't help. Should go for a bony procedure. 5 to 10 years, bony procedure. Okay, and what is that? It is you are reshaping the talus or calcaneum. Okay, that's a bony procedure. Many things are there. One name you should not forget in exam, DIL, W-Y-N, Dillwyn-Evans osteotomy. Dillwyn-Evans osteotomy. Dillwyn-Evans osteotomy. Okay, so this you can try. If it is not corrected even after 5 years, this can be employed only up to 5 to 10 years. So 5 to 10 years, it is bony procedure. You can do a Dillwyn-Evans. Even after 10 years, it is not getting corrected, and the patient is 10 years and above. That is called neglected CTEV. It is called neglected CTEV. It's called neglected CTEV. And neglected CTEV, there is no other option after 10 years. The only surgery that is available is triple orthodesis. Triple orthodesis. Orthodesis. That means you are artificially fusing a joint is called orthodesis. Ortho means joint, desis means fusion. So what are the 3 joints that are fused in triple orthodesis? What are the 3 joints that are fused in triple orthodesis? calcaneocuboid joint, talonavicular joint, subtalar joint. Calcaneocuboid, talonavicular, subtalar. These three joints are fused and this is called triple orthodosis. This is called triple orthodosis. So, just age-wise treatment plan, I will revise once more. 0 to 8 weeks manipulation by mother and Ponseti's technique. 8 weeks to 5 years posteromedial soft tissue release, that's called Turcos procedure. 5 years to 10 years corrective osteotomy of the talus and calcaneum, which is called Dillwyn-Evans osteotomies. More than 10 years triple orthodosis. Okay, so, right? So this is how we should go about in nutshell about CTEV. Then coming to the next topic, congenital dislocation hip. Nowadays this is called developmental dysplasia hip. Nowadays that is called developmental dysplasia hip, DDH. Okay, so it is uncommon in India. Why it is uncommon in India? You and me would have suffered from developmental dysplasia hip. The way we carry our baby, just you used to carry our baby like this. This position in hip of a mother, no, that abduction, most of the DDH will get relocated or get reduced by its own. The way we carry our baby. That's why it's uncommon in Europe, uncommon in India, very common in Europe. See, I said CTEV is very common in boys. CDH is common in girls. You see the ratio 7:1. 7 girl babies is to 1 boy. Okay. It's mostly unilateral, for unknown reasons more common on left hip. This question they have asked. Which side CDH is common? It's on left side. What is the basic pathology? In case of CTEV, I said the basic pathology is primary germplasm defect of the talus. Okay. In developmental dysplasia hip, the primary pathology is delay in ossification of the capital femoral epiphysis. Delay in ossification of the capital femoral epiphysis. So, delay in ossification of capital femoral epiphysis results in two deformities. Small sized head of femur. Small sized head of femur. Head of femur. Okay, this is one deformity. Small and shallow acetabulum. Small and shallow acetabulum. Shallow acetabulum. Okay. So, you see, delay in ossification of the capital femoral epiphysis results in two deformities. One is a small sized head of femur, another is a small and shallow acetabulum. Among the two, the most common thing is small and shallow acetabulum. Okay. Campbell says among the two, the most common deformity is a small and shallow acetabulum. So, primary thing is a small and shallow acetabulum. There will be shortening of the leg and additional crease in posteromedial aspect of the thigh. So, when you make the baby stand from just you see the baby from behind the thighs, normally baby will be having a posteromedial crease. Normally a fold will be there in all the babies. In case the baby is having an developmental dysplasia hip, they will be having an additional crease in posteromedial aspect of the upper thigh. Right. Coming to clinical tests or clinical examination of CDH, one should not forget ortolano's test, Barlow's test, telescopic test, Galeazzi sign. Okay. So, ortolano's test is called test of entry. For remembrance sake, I am telling you, this is called test of entry. Right. Ortolano's test is called test of entry. Barlow's test is called test of exit. I will explain. Okay. Only once I will explain. Please listen. You are receiving a baby and the baby is already having a dislocated hip. You are suspecting it is developmental dysplasia hip. In a calm environment, abduct the hip, internally rotate the hip. The hip will get reduced with a click sound, that is called ortolano's test. Head is entering the acetabulum, so it's called test of entry. Barlow's test is you are suspecting DDH in the child. The child, when you are suspecting it is not having a dislocated hip. Okay, you are suspecting CDH, developmental dysplasia hip. So you are trying to dislocate the hip. So it is Barlow's test is dislocating a dislocatable hip. What is Barlow's test? Barlow's test is dislocating a dislocatable hip. That's called Barlow. Since this is a provocative test, usually in clinical examination, we won't do a Barlow's test. Then comes telescopic test. What is telescopic test? Flex the hip to 90 degree, flex the knee to 90 degree. If it is a dislocated hip, when you push, Because head is not inside the socket. When you push, it will go down. When you pull, it will come up. Push, it will go down. When pull, it will come up. Like a telescope. So it's called telescopic test. Galeazzi sign is beautifully depicted here. You see Galeazzi sign. You make the baby lie down in a supine position. Flex both the hip to 90 degree. Flex both the knee to 90 degree. Normally, both the knees should be at the same level. This is normal. You see here, this side the height is okay. This side, the knee is not meeting this level. So it is shortened. So this is called, this side the patient is having CDH. Both the knees won't be at the same level. It will be shortened. It will be at lower level. That is called Galeazzi sign. This Galeazzi sign is otherwise called Alice test. This is otherwise called Alice test. Okay? Yes. Gait of unilateral DDH is called Trendelenburg gait. Gait of bilateral DDH is called sailor's gait, otherwise called duck waddling gait. This is otherwise called duck waddling gait. Okay. It is more in mature baby, full-term mature baby. It is not common in, the question asked is common in mature or premature. Answer is mature. It's common only in full-term mature baby. It is common in breech presentation and firstborn. Okay. So what are the predisposing factors or associated factors? Number 1, female child. Number 2, full-term child. Number 3, breech baby. Okay. Number 4, firstborn baby. Okay. These are the association. Firstborn female full-term baby of breech presentation. Very high chance of developing DDH. And all these points have been asked in the entrance. And the investigation of choice is a real-time ultrasound. Ultrasound is a better investigation. If the baby is below 3 months, put the baby on Von Rosen splint. That is the treatment. If it is 3 to 6 months, reduce by gentle manipulation under general anesthesia. Reduce it. I told you how to reduce. That is orthogonist test. Abduct and internally rotate. The hip will get reduced. After that, keep it in a plaster with 90 degree hip flexion, 45 degree hip abduction. 90 degree flexion, 45 degree abduction. You should not abduct more than 45. When you abduct more than 45, blood supply to head of femur may be affected and the CDH baby may be going for avascular necrosis of head of the femur. So, 90 degree flexion, 45 degree abduction. That's called human position. And this is the treatment of choice when the baby is between 3 to 6 months. Above 6 months, it's called neglected DDH. You can't do anything. You just allow the baby to mature. After that, you correct it with Shan's osteotomy and Chiari's osteotomy. Both two osteotomies are very famous for a neglected DDH. Okay. Now, we'll move on to another important topic, osteomyelitis. Infection, osteomyelitis. Okay. Just I will tell you the salient point very in a detailed fashion. Osteomyelitis nearly 45-50 minutes I had taken a class. It's there in the main recording. Just you see the main videos. Just I will highlight the points. This is rapid revision. Okay. So define osteomyelitis. Osteomyelitis is infection, inflammation of all layers of the bone. That is cortex, medulla, bone marrow. So it is osteomyelitis is infection, inflammation of the bone plus bone marrow. Okay, bone marrow. This is osteomyelitis. Osteomyelitis is the inflammation of the bone and bone marrow, otherwise all layers of bone. Who coined the term osteomyelitis? French orthopedic surgeon Neleton coined the term osteomyelitis. What are the 3 types of osteomyelitis? Acute, subacute, chronic. When the duration is less than 2 weeks, it's called acute. 2 to 4 weeks, it's called subacute. More than 4 weeks, it's called chronic osteomyelitis, and this classification is called Wald-Vogel classification. Very, very, very important, dear friends. NEET exam. Wald-Vogel classification. Less than 2, 2 to 4, more than 4. Okay? Yes. Then acute osteomyelitis. That is osteomyelitis less than 2 weeks is called acute. Commonest mode of spread is hematogenous and most common in children younger than 5 years. Most common site is proximal tibia. First common site, proximal tibia. Second common site, distal femur. That means commonly happens around knee joint. Osteomyelitis most commonly in children happens in the knee joint. And most common organism, 1 lakh time repeated question, Staphylococcus aureus. Osteomyelitis means unless otherwise proved, it is caused by Staphylococcus aureus. Most common organism below 4 years is very peculiar, H. influenza. I told you already, I don't know what is the correlation between this 4 years and influenza. Wherever in your MCQ 4 years comes, most common cause of meningitis 4 years, influenza. Most common cause of otitis media 4 years, influenza. Most common cause of 4 years, osteomyelitis, influenza. Okay, just have this in your mind. Most common site of acute osteomyelitis in an adult is thoracolumbar vertebra than long bones. I said osteomyelitis is a disorder of children. When it happens in adult, most common site is thoracolumbar vertebra, D12L1, okay, thoracolumbar vertebra than long bones. Pathologically, few days and numbers are very important in osteomyelitis. When pus is formed in acute osteomyelitis? By second or third day. Very important MCQ. When pus is formed in acute osteomyelitis? Only when pus is there, it's called osteomyelitis. When pus, no, when it is formed, it is second or third day. Okay. Evidence of bone death. Bone death means sequestrum, dead bone. Evidence, end of first week. Newborn formation from deep layers of stripped periosteum. That's called involucrum. That's called involucrum. Okay. End of second week. Simple to remember, no, I should insist these 2 points only in chronic osteomyelitis. Why I am telling? Because new numbers in osteomyelitis. Pus is formed on second and third day. Evidence of sequestrum end of 1 week. Evidence of involucrum end of 2 weeks. Easy to remember, no? 2 days, 1 week, 2 weeks. Okay. Most common site of bone. We all know a bone means epiphysis, metaphysis, diaphysis. Osteomyelitis is a disorder of metaphysis. Okay, osteomyelitis is a disorder of metaphysis. Why metaphysis more prone for osteomyelitis? You should remember 2 hypotheses or 2 theories. One is called hobo, another is called trueta. One is called hobo and another is called trueta. What do you mean by hobo's hypothesis? Normally, this is epiphysis, this area is metaphysis. This area is metaphysis. Normally in metaphysis, phagocytic cells are less. Okay. So phagocytes are not there, very minimal or less. So whenever Staphylococcus aureus comes to metaphysis, it is not being phagocytosed. It's not being killed by phagocytes. So osteomyelitis is more common in metaphysis. This is called Hobo's hypothesis. Phagocytic theory. Okay. Phagocytic theory. This is called Hobo's hypothesis. Second hypothesis I told you is Trueta's hypothesis. Because see, you are seeing medullary artery. This is medullary vein. Medullary artery comes in the metaphysis. It's becoming a bend like this. Okay. And again, medullary vein bends like this. So, totally this is forming hairpin bend like vessels in the metaphysis. So, just imagine, dear friends, if it is a straight artery like this, no, when an organism is being carried in the blood, I said the spread is through blood, hematogenous spread. So, an organism, when it strides just away speed in a speedy fashion, it can go like that. Okay, in a speedy fashion, it can go like that. Right. But you see, here there is a hairpin bend vessel. So, whenever an organism speed, it will come here, then slowly it gets slowed down. It gets slowed down because there is a hairpin bend vessel. When it is slowing down, the Staphylococcus organism, the organism can escape from here, gets lodged in the metaphysis. Already phagocytes are not working. So, more chance of forming an abscess or inflammation here. So, this hairpin bend vascular theory, hairpin bend theory is called Trueta. Okay. Hairpin bend. Okay. theory is called Trueta. So two theories. Why osteomyelitis is common in metaphases? Because of less phagocytosis, Hobo's hypothesis. Because of hairpin bent vessels, the blood, sluggish flow of blood, so that organism can escape. That's called Trueta hypothesis. Okay. In infant or child below 1 year, it involves epiphysis also. And very common presentation in a child with acute osteomyelitis is pseudoparalysis. Pseudoparalysis means real problem is not, no neurological problem is there. You know, periosteum is very sensitive. Whenever there is inflammation, there will be inflammation of the periosteum also, and abscess will be there. So what happens, no? When the child moves the limb, it causes severe pain in the leg or affected part. So because of pain, that the baby won't be moving that affected limb. It looks like paralysis, but it's not a true paralysis. So it's called pseudoparalysis. Whenever pseudoparalysis in ortho comes, three differential diagnoses: acute osteomyelitis, scurvy, congenital syphilis. Okay, so I had discussed these 3 points in a detailed fashion in the main recording. Please watch back. Okay, whenever pseudoparalysis in orthopedics, think of 3 differential diagnoses: acute osteomyelitis, scurvy, and congenital syphilis. X-ray is normal during the first 10 days of life, first 10 days of the infection. By end of second week, you can see the periosteal newborn formation, classical sign of acute pyogenic osteomyelitis. Whenever it shows a regional osteoporosis, it says that metabolically active living bone. A segment of increased density obviously says it's a dead bone. Okay, so MRI is extremely sensitive in early phases. Radioscintigraphy with gallium citrate, highly sensitive but less specific. Most certain way of confirming the diagnosis is putting a needle, aspirating, seeing the pus with your own eye. Direct evidence of osteomyelitis. So the best investigation is aspiration of the pus. Okay, but it's an invasive investigation, so we won't do. So among the non-invasive investigation, best investigation for acute osteomyelitis is MRI. Okay, you can't rely too much on X-ray. Treatment of acute osteomyelitis: just supportive therapy for dehydration and pain, splintage of the affective, immobilize the affected part, give appropriate antibiotic. Surgical drainage is the last option. For acute osteomyelitis, try to manage conservatively with medicine. Older children and adults with staphylococcal osteomyelitis, the best treated with flucloxacillin plus fusidic acid. Okay, fusidic acid. And children below 4 years, I said influenza osteomyelitis is more common, so second generation cephalosporin. Very peculiarly, a subacute osteomyelitis called salmonal osteomyelitis, book says treatment drug of choice is cotrimoxazole, very old drug, but that is what they had mentioned. Streptococcal osteomyelitis, benzyl penicillin. Okay, so when will you do surgery or when will you try to aspirate the pus? If constitutional symptoms or local pain fails to improve within 36 hours, drainage is mandatory. Complications of acute osteomyelitis: septicemia, septic arthritis, growth disturbance, chronic osteomyelitis. Because when it goes and affects the epiphysis, it can cause growth disturbance. When you don't treat properly from acute, it can become chronic. Okay, so when it involves the epiphysis, goes inside the joint, that's called septic arthritis. This is otherwise called Tom Smith's arthritis. This is called Tom Smith arthritis, the child. Okay, Tom Smith's arthritis, when the child is below 1 year. And the most common joint involved is hip joint. Tom Smith's arthritis, 2 questions they had asked: age group less than 1 year, it will go inside the joint. The most common joint that is involved is hip joint. Subacute osteomyelitis, there will be well-defined cavity in the cancellous bone. Again, it is Staphylococcus aureus. There are 3 main types of subacute osteomyelitis. One is called Brody's abscess, next is called Gary's osteomyelitis, and third is called salmonal osteomyelitis. Okay, Brody's abscess, Gary's osteomyelitis, salmonal osteomyelitis. Brody's abscess is a localized abscess in the cancellous bone. Most common site is upper tibia. Most common organism, Staphylococcus aureus. Most common age group, second decade. Low virulence of the organism and good host resistance leads to confining the infection inside, like a small cavity inside the cancellous bone. That is called Brody's abscess. Okay. Right. Gary's osteomyelitis is a dry osteomyelitis. Osteomyelitis means pus should be there. One exception is Gary's osteomyelitis. Diffuse sclerosis in the metaphysis is seen. It's a dry osteomyelitis. Okay. And it is common in diaphysis. The most common bone, no? Most of the MCQ books gives a wrong answer. They're telling the most common site is jaw, mandible. This is the second common site. Most common site of Gary's osteomyelitis is also upper tibia. Okay, good. Typhoid osteomyelitis, the common bone involved is ulna. This is a special point for you. And it most of the time, whenever you come across typhoid osteomyelitis, kindly rule out sickle cell anemia in that patient, sickle cell disease. And treatment of choice for salmonal osteomyelitis is surgical drainage. If at all you want to give a drug, you give cotrimoxazole. Already I told you, okay, cotrimoxazole. And chronic osteomyelitis persisting more than 4 weeks according to Wald-Vogel. That's called chronic osteomyelitis. Most common cause is Staphylococcus aureus. And in foreign body implant, it can be Staphylococcus epididymis, otherwise called Staphylococcus albus. The classical feature just I want to highlight is the Wallenkamp phenomena. What do you mean by Wallenkamp phenomena? What happens, no? Wallenkamp phenomena is a waxing and waning phenomena. What is that? What happens in chronic osteomyelitis? In the pus, everything gets accumulated inside the bone. Okay, pus will be there, right? The hallmark of chronic osteomyelitis is sinus. Only when there is a sinus, okay, it's a hallmark of chronic osteomyelitis. What happens? Pus gets accumulated inside the bone, the metaphysis. Patient will develop all toxic symptoms. Toxic symptom means severe pain, swelling, fever. Once what happened? Breakage of the skin when pus got drained out. When pus goes out, drained out, all the toxic symptoms, everything will come down and it will go for a temporary healing even without treatment. That is called Wallenkamp phenomena. So it's a cyclical phenomena. So after sometimes again pus starts accumulating, patient will develop toxic symptoms, skin breaks open, pus drains out, symptoms improve. This is called the cycle. This is called Wallenkamp phenomena. That's called Wallenkamp phenomena. And on sinus discharge, when you see direct bone chips, it's very pathognomonic. Very pathognomonic. Yes. What's a sinus? What's a fistula? Everything this you know already we had discussed. Can you differentiate tuberculous sinus from pyogenic sinus? Definitely. If it's a tuberculous sinus, the edges of the sinus, the wall, the edges of the sinus, no, will have a bluish discoloration. Okay. Bluish discoloration. Number 2, second point. When you touch, you see there will be hyposthesia. Okay. Hyposthesia. Decreased sensation, hyposthesia. Okay. What is a sequestrum? A dead bone is called a sequestrum. A dead bone is called a sequestrum. Sequestrum has 2 surfaces. Outer smooth surface, inner rough surface. Outer smooth surface is because the outer surface is in communication, is in communication with the pus. Is connected to the pus. So smooth. Inner surface is in touch with the granulation tissue. So it is rough. Okay. So that is these are the 2 things. And according to types of this several times repeated MCQs, kindly please take down or just listen. Already I had taken very detailed fashion. Just I am repeating it. See, according to the shape, a pencil shaped sequestrum, like a pencil. A sequestrum can come like a pencil. Diagnosis, it's seen in infant. Chronic osteomyelitis in infants. A ring shaped sequestrum in pin tract infection. You are putting an external fixator, putting a shank screw, a pin. Okay, when osteomyelitis happen in the pin tract, the sequestrum coming out will be ring shaped. Okay, ring shaped pin tract infection. Conical sequestrum, amputation stump. Coralliform, like a coral, coralliform Perthes disease. According to consistency, Coke like. Okay, Coke means most of us think it's a drink. Coke is a product which is obtained from the coal, a tar like product which comes from the coal. That's called Coke. Exactly the drink Coke, the color is like that, the consistency like that, so they named that as Coke actually. Coke is a product which is obtained from the coal. Okay, so like that, when the consistency, Coke-like sequestrum, it's tuberculous chronic osteomyelitis. Feathery, like a feather, it is syphilis, outdated condition, syphilis. Sandy, like a sand, it's tuberculous. These questions and all 1 lakh time repeated this year also. Again, this will come, dear friends. Kindly make a note. And according to color, a blackish sequestrum, It is fungal or amputation stump. A green sequestrum, Pseudomonas infection. Investigations. X-ray. The cortex of the infected bone becomes thicker and irregular with disorganized trabecular pattern. Radiological features of chronic osteomyelitis. Cortex becomes thickened and irregular. Disorganized trabecular pattern. Classical X-ray picture is patchy loss of density. Clear evidence of sequestrum in radiology appears by 4 to 6 weeks. Sequestrum appears denser compared to the surrounding bone. The most important thing is, please underline this point, because in image-based question and clinically based question, this is the question. When there is loss of corticomedullary differentiation, the only diagnosis is chronic osteomyelitis. You see here, dear friends, look at this part. Just this is some pathological X-ray only, but you see, I am able to see a cortex here. The part inside, the part inside, it is the medullary canal I am seeing. In this area, I am not able to see which is cortex, which is medulla. Everything looks the same. So this is called loss of corticomedullary differentiation. Here you are able to see the medullary canal. Here you are not able to see any medullary canal. Loss of corticomedullary differentiation. The only diagnosis in the whole world, chronic osteomyelitis. Sinogram, when you have multiple sinus, sinogram may be done. Radio-opaque dye is injected and read with X-ray or CT. The major role of CT scan in chronic osteomyelitis is detection of the sequestrum. Sequestrum is well seen in CT than normal X-ray. MRI provides an accurate determination of the extent of the pathology in bone and soft tissue. It shows sinus tract also. So MRI, among non-invasive investigation, MRI is the investigation of choice. Coming to treatment of chronic osteomyelitis, 4 important steps are radical debridement. Radical debridement means removing all the dead thing. Then a dead space is created. You have removed a part of bone means a dead space is created. So you patch up the dead space. Third, soft tissue coverage. Only when you cover it soft tissue, blood supply will be maintained. Soft tissue coverage. Number 4, appropriate antibiotic therapy. Radical debridement is achieved by sequestrectomy and saucerization. Treatment of choice. 10 lakh time repeated MCQ. Conversion of the hollow cavity, okay. So next, dead space. After radical defect in the bone and soft tissue are formed, this is called dead space. If the dead space is not treated properly, it will lead to early recurrence of the infection. The various method of dead space management is Papini-Reedlander's technique, VAC therapy. Okay, this is VAC means vacuum assisted closure. Antibiotic, PMMA is polymethoxymethyl acrylate, which is bone cement. So antibiotic impregnated bone cement, filling the dead space with that. Okay, so these are the techniques. Then soft tissue coverage can be extensive scarring muscle. So treat this coverage when done by muscle flaps. Okay, and antibiotic for Staphylococcus aureus, IV nafcillin or cefazolin is the latest thing they are mentioning. If it is methicillin resistant Staphylococcus aureus, obviously it is vancomycin. We will try the penicillin group first. This nafcillin is a methicillin group first. Nafcillin, if it is not acting, vancomycin, methicillin resistant vancomycin. If it is vancomycin is not acting, vancomycin resistant, we'll go for linezolide. Okay, linezolid. Okay, linezolide. Vancomycin resistant, will go for linezolid. Okay, antibiotic is given for 4 to 6 weeks. This is very important. Reason being, it takes 4 weeks for revascularization of the bone, by which antibiotic agents are able to infiltrate the site of infection. Whenever you are giving antibiotic, it should go and reach the infection site, So revascularization takes minimum 4 weeks. So when you give at least for 6 weeks only, the antibiotic will act. If you give for 5 days or 7 days, there is no use of giving antibiotic in case of chronic osteomyelitis. Complications of chronic osteomyelitis: acute exacerbation of the symptom, growth disturbances if epiphysis is involved, pathological fracture, because sequestrum means a dead bone. Part of bone is dead and it comes out. Bone becomes weak, so that part can go for pathological fracture. Sinus tract is lined by squamous epithelium, so epithelioma, and secondary amyloidosis. Secondary amyloidosis is a cause for nephrotic syndrome. So these are the complications of chronic osteomyelitis: an acute exacerbation of symptom, growth disturbances, pathological fracture, epithelioma, Secondary amyloidosis leading to nephrotic syndrome and renal failure. So these are the complications of chronic osteomyelitis. We'll move on to the next topic, tuberculosis of bone. Tuberculosis, skeletal tuberculosis in general, highest incidence in young adults. Osteomyelitis in children, skeletal tuberculosis young adults, uncommon in old age. Okay, it's uncommon in old age. Human type of there, because there are two types of tubercle bacilli. One is called a bovine type, another is called a human type. In our country, human type is more common, bovine type is uncommon because we are pasteurizing the milk and after that only we are drinking. Most common route of spread of this thing like osteomyelitis, it is hematogenous through blood spread. 90% of the skeletal tuberculosis origin should be from a primary pulmonary tuberculosis. Okay, primary skeletal tuberculosis is only rare. And infection, the first site of affection is epiphyseal cartilage. Several times asked question. Okay, the first site of infection in skeletal tuberculosis is epiphyseal cartilage. There are two types of tuberculosis. One is called a caseating type, another is called a proliferating type. Caseating type is the common type. Proliferating type is called Kericica, a dry type of tuberculosis. Okay, the caseation won't be there. And synovial biopsy is the only confirmatory test. Epiphyseal cartilage is no barrier. Only in vertebra and greater trochanter of the femur, the infection persists as chronic osteomyelitis. Healing of tuberculosis is by incomplete ankylosis. This is called fibrous ankylosis. This is called fibrous ankylosis. Okay, right? Ankylosis. Okay. So, night cries is very characteristic. What do you mean by night cries? What do you mean by night cries? Patient will go to sleep. In the daytime, they won't be having much pain. They will go to sleep. In deep sleep, patient will get up from the sleep. They can't bear the pain and they start crying, literally crying. Usually this happens around early morning hours, around 3 a.m., something like that. So, what is the mechanism? Because what is the cause for night cries? During daytime, we are very active walking here and there. All the skeletal muscles are contracted. So, tuberculosis of the joint, skeletal tuberculosis, the focus is in the synovium. Okay. So, skeletal muscles, when they are contracted, they are around the synovium. It compresses the synovium like a cast. When we go to sleep, what happens? The skeletal muscle gets relaxed. In deep sleep, all the muscles are relaxed. So, synovium starts stretching. The stretching causes the pain. Because synovium is extremely sensitive, richly supplied by nerves. So, stretching of the synovium causes the stretch pain, what they experience, and that is the cause for night cries. So, dear friends, whenever a word night cries comes in orthopedics, two differential diagnoses. One is skeletal tuberculosis, another is osteoma. Okay, another is osteoma. So, two causes for night cries in orthopedics: osteoma, osteoid osteoma, and next is skeletal tuberculosis. Soft tissue, X-ray shows soft tissue swelling and periarticular osteoporosis. Whenever a word in your radiology comes periarticular, around the joint there is osteoporosis. The diagnosis is skeletal tuberculosis. Diagnosis is skeletal tuberculosis. The articular margins and bony cortices becomes hazy, and that is called washed out appearance. It's called washed out appearance. Articular space is narrowed, and you should be familiar with a thing called Phemister triad. GERD triad we had seen in fat embolism. Phemister triad. Phemister triad. What are the three things, radiological features? Periarticular osteoporosis, peripherally located bony erosion, joint space narrowing. So, Phemister triad is a very classical radiological finding of skeletal tuberculosis. Joint space narrowing, periarticular osteoporosis, peripherally located bone erosions. These three things are called Phemister triad. So, they may ask in exam in radiology, Phemister triad is characteristic of skeletal tuberculosis. Okay? Yes. Medical management in general of skeletal tuberculosis, first line drugs are INH, rifampicin, ethambutol, streptomycin, pyrazinamide. 5 drugs. Okay? INH, rifampicin, ethambutol, streptomycin, pyrazinamide. Please go and just revise from your previous recording, that's main recording. had elaborated. INH means what's the dose, main complication, everything I had elaborated there kindly. For first line drugs, 5 drugs. Okay. Second line drugs, thiazolone, paraminosalicylate acid, ethanimide, cycloserine. For skeletal tuberculosis, WHO recommends category 1 treatment, CAT 1. It's usually in MCQ, it comes as CAT 1 treatment in pharmacology. CAT 1 means, what is that? Category 1 treatment. For 2 months, you are giving INH, rifampicin, pyrazinamide, ethambutol. 4 drugs for first 2 months. Then for another 4 months, you are giving just INH and rifampicin alone. So this is called CAT 1 treatment. Okay, that is generally followed. And usually for skeletal, this is 6 months regime. For skeletal tuberculosis, we will extend up to 9 months usually in skeletal tuberculosis. So the most common site that is involved in skeletal tuberculosis is spine, and that's called Pott spine, named after the great Percival Pott. Okay, Sir Percival Pott. And the most common site is thoracolumbar vertebra. This is what given in the English textbooks. So dorsolateral vertebra, especially D12. First common site. Second common site, L1. Okay, D12, L1. Most common site is D12. Why? I told you, D12 in wedge compression fracture chapter. D12, most weight bearing vertebra. And that's the most common site. And it is common during first 3 decades of life. Tuberculosis, spinal tuberculosis can manifest in one of the following ways. It can manifest as cold abscess. It can manifest as paraplegia. It can cause progressive bony destruction leading to vertebral collapse and kyphosis. Some patients will present you with kyphosis. Some can present you with paraplegia. Some can present you with simple cold abscess. Primary site of infection most of the time is pulmonary. I told you 90%. Involvement of the vertebra is usually due to hematogenous spread, either through an arterial or venous route. Look at the diagram, either through arterial plexus or venous plexus. The arterial arcade is the subchondral, in the subchondral region, facilitates spread of the infection to the paradiscal area. Okay, so arterial in the paradiscal area. Okay, if it is venous plexus, that's called Batson's plexus. Several times repeated MCQ. Batson's paravertebral venous plexus, which is valveless plexus, is responsible for spread of infection to the center of the vertebral body. You see, this Batson's plexus goes into the center of the vertebral body. So infection gets lodged here. So whenever there is infection in the center of the body, mostly that is through Batson's plexus. Whenever there is infection paradiscal, that is around the disc, paradiscal area, that is due to arterial arcade. Spinal tuberculosis normally starts in the antero-inferior portion of the vertebral body. Later it spreads to the central part of the vertebral body. Paradiscal anterior and central lesions. Rarest site in the posterior element. What do you mean by posterior element? The pedicles are posterior element. Transverse process of the spine, spinous process of the spine. These three, they are called the posterior elements. Rarest site of involvement. Usual clinical symptom is painful stiff back. Systemic symptoms most of the time will be absent. It won't be present. Classical night cries. Already I had explained to you what is the meaning of night cries. First deformity on inspection to be seen is loss of normal lordosis in the cervical and lumbar area. Loss of cervical lumbar lordosis. That is the earliest deformity to happen. 1 lakh time repeated MCQ. Second deformity is gibbous. Gibbous is very common in thoracic spine. What do you mean by gibbous? Crowding of the spinous process. 2 or 3 spinous processes crowd together, form like a hump. When you palpate, you can palpate like a hump. That is called gibbous. That is the second common deformity. First common deformity is loss of cervical and lumbar lordosis. I told you in the main recording, I explained each and everything in detail. Just go and watch. I will tell you what is a wall test. I had already explained this wall test. Wall test, ask the patient to go and stand near a wall like this. Normally, because of cervical lordosis and lumbar lordosis, can be able to insinuate the finger, the cervical and lumbar. If there is loss of cervical and lumbar lordosis, you cannot insinuate that lordosis is lost. You can't insinuate the finger between the cervical vertebra and the wall, and that is called the wall test. Okay, it is very famous Clinical test. Okay, paraplegia that's caused by part spine is usually spastic type. Earliest X-ray sign or radiolucency and loss of definition of the plate margin. This is called washed out appearance. Okay, washed out. Already I told you. 4 common sites of vertebral involvement are, you see here, here is your disc. Here is your disc. So this is the common area. So this is called paradiscal. That is called paradiscal. Okay, paradiscal. Most common. Second thing, center of the body of vertebra. This is by your Batson's plexus. Second common. Third thing, anterior part of the vertebra. This is not 1. This is 3. Anterior part of the vertebra. And the rarest site is posterior element. Rarest site is posterior element. Posterior element, I told you, spinous process, lamina, all the pedicles. They are the posterior elements. Rarest site. Cold abscess in the thoracic region shows typical fusiform shaped shadow, and that is called bird nest appearance. That's called bird nest appearance. CT scan remains the preferred imaging modality for assessment of destruction of the vertebral body and sequestrum formation. It will give you more clear picture than X-ray. There is no doubt. Look at the next point. MRI. MRI. What is that? Among various types of imaging modalities, MRI has the ability to diagnose the disease earlier, more accurately. More than that, it is useful in assessing the spinal nerve root compression, discitis, paradiscal soft tissue lesion. So, among non-invasive investigation, MRI is the investigation of choice for spinal tuberculosis, like osteomyelitis. Okay. Biopsy, percutaneous CT guided biopsy is preferred since it's an invasive investigation, routinely not done. Chemotherapy for part spine should be continued for at least 9 months. I told you earlier, skeletal tuberculosis in general, for tuberculosis of hip, tuberculosis of spine, tuberculosis of knee, wherever there is skeletal tuberculosis, normally it's followed for 9 months. Okay. And you should know our great SM Tully's middle path regime. Okay. Professor Tully, SM Tully, very famous works in tuberculosis, skeletal tuberculosis. Dear friends, you should never forget few Indian forefathers. Their work, internationally followed regimes. T.K. Shanmugh, Professor T.K. Shanmugh Sundaram sir. Another is Professor SM Tully sir. These 2 names you should never forget in skeletal tuberculosis. Extensive work in skeletal tuberculosis worldwide. They are following this regime, which is called Professor SM Tully's regime, middle path regime. It's called middle path regime. What is the thing? No, the very idea of Professor Tully's middle path regime is to avoid unnecessary surgery. Avoid unnecessary surgery. First, rest is given, adequate rest is given. That too, it's provided in a hard board. Okay, in a PO, previously they were using POP. It's not needed now. Hard bed, just a hard board. First. Number 2, appropriate and correct methodical anti-tuberculosis drug. I told you for first 2 months, you give 4 drugs. The next 7 months, you give 2 drugs. Okay, first line drugs. Then follow up. How you are following? Followed every 3 months. X-ray and ESR are used as prognostic indicators. ESR should come down. X-ray should not get worsened. It will show you some sort of improvement. Then 4th step is gradual mobilization is done in patients with no neurological deficit with help of spinal brace, Taylor's brace, spinal brace. Okay, with the spinal support, they can slowly walk. Okay, finally, surgical indication is only when there is no recovery after fair trial or neurological symptoms worsens. Indications for surgery according to Professor Tully's regime with neurological deficit. No recovery after 3 to 4 weeks of drugs. There is already a neurological deficit. You are strictly giving ATT. You are doing everything. You are giving rest ATT. In spite of good ATT and rest, their neurological deficit is not recovering by 3 to 4 weeks. You have to go ahead with surgery. Paraplegia getting worsened, immediately should take for surgery. This is with neurological deficit. If somebody is having spinal tuberculosis but they are presenting without any neurological deficit, then when will you do surgery? Extensive paravertebral abscess, not responding to ATT. ATT is not going and reaching that spot. No other go, you have to drain it out, surgical. Number 2, mechanical instability. Example, disease affects the facetal joints and the spine has become There is no neurological deficit, but the vertebral column is not stable. It's unstable. You have to go and fix it. Okay, the surgery is needed. Then operations that are available are costotransversectomy, anterolateral decompression, anterior decompression, spinal fusion. This is called Hong Kong procedure. Posterolateral or transpedicular. Posterolateral, or transpedicular approach is used extensively for management of spinal tuberculosis, because in recent one of the entrance MCQ, the approach they had asked, posterolateral approach is the commonly used approach, because anterior approach is there, posterior approach is there. Posterolateral is the very commonly used approach for Carey spines. Coming to tuberculosis of the hip joint, next to spine, hip is the most common joint that is involved in general. Most common site of affection in tuberculosis in children is hip joint. Okay, tuberculosis in children is hip joint. Spinal tuberculosis common in, I told you, young adults. The initial focus of tuberculosis lesion in hip starts at any part of the following. It can be followed the most common site. It is acetabular roof. It is the acetabular roof. Number 2, epiphysis of the femoral head. Number 2, okay, epiphysis of the first site is acetabular roof. Second site is epiphysis of the femoral head. Third, metaphysis of the femoral head. That is neck. Metaphysis of the femoral neck. This area. This is called Babcock's triangle. This is called Babcock's triangle. Number 4, greater trochanter. Number 5, it can be in the synovial membrane. It can be in the synovial membrane. Number 5, it can be in the synovial membrane. So these are the common sites. So once a question was asked, I said no, where the first site of infection of skeletal tuberculosis epiphyseal, I told you, the usually paradiscal area very commonly affected in spine. Center of body of spine is very much affected. So like that, if they ask which is very commonly or earliest site that is, or most common site that is involved in tuberculosis of the hip joint, we have to answer acetabular roof. Okay, good. Clinical feature very common in third decade of age, night cries. They will have an antalgic gait, restriction of joint movements, that's okay. And the Babulkar and Ponde's clinical classification, I'm not going to into detail, just I'm going to outline. First stage is called stage of synovitis. Second stage is called stage of early arthritis. Third stage is called stage of late arthritis. Stage 4 is called stage of pathological dislocation. In case of stage of synovitis, just the terminal range of movement is restricted by 25%. Stage of early arthritis, all range of movement are restricted by 50%. Okay. And in case of say late arthritis, there is true shortening, significant destruction, gross restriction of movement, you can't do. And stage of pathological dislocation, totally what happens, gross destruction of the femoral head, and the upper end of the femur may be displaced upwards dorsally, outer aspect of the ilium. This is called traveling acetabulum, otherwise called wandering acetabulum. Okay, that is called wandering acetabulum. Okay, so stage of pathological dislocation. Then coming to treatment of tuberculosis of hip, stage of synovitis, just rest, skin traction, ATT. If it is stage of early and late arthritis, ATT, not weight bearing, range of movement exercise, unresponsive case, you have to go for synovectomy and joint debridement. Synovectomy and joint debridement. This was the question, recent question. Okay. Treatment of choice, a stage of arthritis of tuberculosis of hip. It is synovectomy and joint debridement. Joint debridement means you are approaching the joint, you are clearing away all the unwanted or dead tissues in the joint. Joint debridement. If it is stage of pathological dislocation, stage 4, Babulkar, girdle stones, excision, arthroplasty. Start the patient on ATT, calm down the infection, knock down the infection. After that, the only treatment is total hip replacement. Tuberculosis of knee is the third common site. Initial focus is in the synovium. Initial focus is in the synovium. And you should know what is triple deformity. Triple deformity is subluxation of the tibia posteriorly, shifted laterally, rotated externally. Okay, tibia is shifted posteriorly, shifted laterally, rotated externally. These three is called triple deformity. This is due to spasm of the biceps, hamstrings and iliotibial band. Treatment of choice for tuberculosis of knee joint is ATT, skin traction, synovectomy and joint debridement, and in worst cases, total knee replacement. Coming to the next important topic, rickets. Rickets, it is due to deficiency of vitamin D. What is the difference between rickets and osteomalacia? Rickets is vitamin D deficiency happening in a immature skeleton, that is before epiphyseal closure. When vitamin D deficiency happens above after epiphyseal closure, that's called osteomalacia. Very simple. So here the basic pathology, osteoid formation is normal, mineralization is defective. 10 lakh times repeated MCQ. There are two types of rickets. One is called nutritional rickets, another is called renal rickets. Renal rickets is otherwise called hypophosphatemic rickets. Okay, hypocalcemic ricket, hypophosphatemic rickets. Nutritional rickets is hypocalcemic ricket. In this renal rickets is called hypophosphatemic rickets. Most common type of rickets throughout the world is hypophosphatemic rickets. Harrison says this. Most common type of rickets in our country still it is nutritional rickets. So carefully read the question and answer. Most common age is around 4 years. Broadening of metaphysis transversely and epiphysis vertically, very classical change. And there are two fontanelles, anterior fontanelle, posterior fontanelles. Normally posterior fontanelle closes by birth. At the maximum it will get closed by 6 months of age. Anterior fontanelle should get closed by 18 months of age. If you are seeing a case and the fontanelles are not closed even by 2 years, the first diagnosis is rickets. The skull changes are called hot cross bun. I had explained everything in detail in main recording. Kindly go and refer hot cross bun. Second is called a ping pong skull, otherwise called a messy one sign. This is called craniotapes. When you press the skull, because the osteoid formation is normal, mineralization is defective, the skull is very pliable like a plastic. When you press it will go down, when you leave it will come out. Okay, so that's called a ping pong skull or a messy one sign, otherwise called this is called messy one sign. Right, and the chest, it will give a ricketic rosary, otherwise called rachitic rosary, which is called beaded ribs. The ribs are beaded, painless. The ribs are beaded, painful, scurvy. That's called scorbutic rosary. The pigeon chest will become pectus carinatum. That's called like a pigeon's chest, pigeon chest. Okay, right. Serum calcium and phosphates are low, but alkaline phosphatase is high. Diagnosis is nutritional rickets. Okay. When serum calcium is normal, phosphate is low, then it is hypophosphatemic rickets. Earliest change it is seen in the skull. And the X-ray you see thickening and widening of the growth plate. Okay, thickening and widening of the growth plate. Cupping of the metaphysis. Okay, because you see this is cupping, more depth. Cupping of the metaphysis. Okay, you see this X-ray, cupping of the metaphysis. Then what is that? Next is fraying of the metaphysis, right? Looser zone. What is looser zone? It's a zone of translucency in epiphyseal-metaphyseal junction, which will cause a pseudo fracture like Ling. It's called milkmaid fracture or stress fracture. So it's called looser zone. A zone of translucency in epiphyseal-metaphyseal junction. Okay. Then they can have a biconcave vertebra. This is otherwise called codfish vertebra. Okay, this is otherwise called codfish vertebra, biconcave vertebra or codfish vertebra. The patient can have a trefoil pelvis, otherwise called triradiate pelvis. Trefoil pelvis or triradiate pelvis. Okay, triradiate pelvis. Spontaneous fracture of ribs. So these are the radiological changes. What are the radiological changes you can expect in rickets? Thickening and widening of the growth plate, cupping of metaphysis, fraying of metaphysis, splaying of metaphysis, looser zone, otherwise called milkmaid fracture. Okay, biconcave vertebra or codfish vertebra, trefoil pelvis or triradiate pelvis, spontaneous rib fracture. Then comes familial hypophosphatemic rickets. This is called renal rickets. Commonest cause of rickets now worldwide, not in India. Worldwide. It's an X-linked dominant, 10 lakh time repeated MCQ. Serum calcium is normal. It is very resistant to vitamin D needs. The initial loading dose may be 50,000 units. Then comes scurvy. Scurvy here, osteoid formation itself is defective. There in rickets, osteoid formation is normal, mineralization is defective. Here, osteoid formation itself is defective. So it's an intrauterine pathology. It occurs between 6 months. It usually manifests 6 months and 2 years of age. Defective collagen synthesis, so osteoid formation becomes defective. And the X-ray, most marked in long bone metaphysis. Okay, so what are the X-ray changes there? You can see in X-ray a periosteal hemorrhage. You can see a tremor field zone. Okay, tremor field zone, and then a dense zone of provisional calcification of the epiphysis. Look at here, tremor field zone is seen in the metaphysis. Epiphysis, you can see a dense zone of provisional calcification. That's called white line of Frankel. You can see Wimberger's line. You can see Wimberger's line, Wimberger's ring. Okay, Wimberger's ring, and you can see at the edge of that, you can see what's called a Pelkan spur. So the radiological features, everything in detail, what is what I had explained in the main video. Just I am outlining the name alone. What are the radiological signs you can expect in scurvy? Subperiosteal hemorrhage, tremor field zone, white line of Frankel, Wimberger's ring, Pelkan spur. Okay, that completes scurvy.